some of these publications in the Nigerian Journal of Clinical Pharmacy and Therapeutics, and also in the Journal of Current Biomedical Research, and other journals. You can find some of our research work, as you can see from my slide here. And interestingly, one of our research work that we supervised by our outgoing intern has been approved for poster presentation in the upcoming FIP conference that is taking place in Copenhagen, Denmark, which we are sure that our intern is going to make us proud. It's a work that we supervise in our facility. So we also have other publications that have been accepted for publication, and also there are also other ongoing research that have been going on that very soon, when you go to those journals that I mentioned, you will see what we are working on. Then this is a cross-section or a picture collage of some of our training activities in our facilities at our departmental level and also in the unit level. Just a cross-section showing our clinical activities. What about when it comes to pharmaceutical care activities? In fact, we have pharmaceutical care forms through which we document what we do. We are all aware of the slogan, if it is not documented, it's not what? It's not done. So whatever we do, we ensure that we document. And these forms are available in all the 18 satellite pharmacies so that each unit can record or document what they are doing. In fact, right now we are also trying to upgrade what we do. We are working on pharmaceutical care logbook so that each pharmacist would have a logbook and report what he or she is doing. Also on the slides, as you can see, there is our pharmacists on ward rounds. We are very present and active in the wards. In fact, we also are very active when it comes to the hospital grand rounds that are being carried out on a monthly basis. So this is just an example of one of our pharmaceutical care interventions. It's a case of a 7-year-old boy who presented with nephrotic syndrome. The doctor prescribed prednisolone for him 60 milligrams daily for 3 months. Our pharmacist, with the use of electronic medical records, was able to check the child's history and found out that this is not the first time that this child has been prescribed prednisolone. The patient has been on prednisolone for a very long time, so our pharmacist knew that she needed to do something. So tactfully, she approached the prescriber and helped him to see that the guidelines suggest that when it comes to nephrotic syndrome, the guideline is that you prescribe 60 milligram start for 6 weeks, daily for 6 weeks, after which you now reduce to 40 milligram, and thereafter you now taper till you gradually withdraw. The physician was very impressed with the way the pharmacist handled that. So it was a win-win for both parties. Both the physician was happy, and also the patient relative were also happy for that intervention that was done by our colleague. So this is also how we evaluate our pharmaceutical care intervention. How do we do it? First, I would like to talk about our interventions first of all. As you can see, like I mentioned earlier, our interventions per week is 50 per week. Then on a monthly basis, that's about 217, and annually we record an intervention of about 2,600. And this is reported from the 14 out of 18 satellite pharmacies that are available in our facility. And when it comes to ward involvement, like I mentioned earlier, we are very active and present in the ward. And some of the roles we play in the ward is such as we identify drug-related problems. We also provide clinical recommendation and also ensure safe and effective medication use. And we also how do we now assess what we do? We also use case audits through which we audit what is being done. And so far, when it talks to stakeholder recognition, both the physicians and the nurses and both the management are happy with our presence and our activities in the ward. So what have we achieved so far when it comes to outcomes? As a result of our DRF outcomes in UATH, our NHS enrollment has moved from about 9,000 to 40,000. Our weekly revenue has also moved from 17,000 to about 26 million. With the use of electronic medical records, we've also been able to achieve data-driven practice such as stock tracking and prescription pattern analysis. Also, when it comes to public engagement, we are very big when it comes to public engagement. As part of our public outreach activities, the Department of Pharmacy, in collaboration with Community Health Medicine, has established a pharmacy in one of the rural settings around Gwagwalada, through which we extend these pharmaceutical activities also to nearby communities. These also some of our activities, a cross-section of the PCN accreditation team that visited our facility. And also, how do we handle conflict and resolution? We have a constructive mechanism through which we handle conflicts. We are also very present in... thank you for listening.
Thank you very much. We are calling on second presenter, Pharmacist AHAPEN Ekedegwa from FMC Asaba.
Your time starts now.
Good morning. Please permit me to stand on already established protocol. My name is Ekedegwa Daniel Ape. I'm going to present on pharmaceutical care practices in FMC Asaba. We'll be running with these outlines. These are some of the abbreviations that we are going to be seeing. pharmaceutical care activities. TPN, total parenteral nutrition, is also a very key service that we deliver. In fact, the physicians send us consult like they do to every other unit of every other clinical unit. So it is not just that we are doing it through the back door, but they invite us, we do make our input, and we influence the therapy, and the patients are very happy. The interventions we do are also documented properly. We have a constant drug assurance by our quality control. We have outreach going to the NYC camp. Then we do treatment reviews, actively doing drug information service. In fact, the state consulted us to do a work on availability of poisons, and what we give to them is what is being used in Delta State currently. Then what about level of acceptance? Acceptance is very, very high. It has grown over the years. This is also evident in the fact that we have 15 fellows, and all the 15 fellows were appointed consultant pharmacists, which is an indication of the good working relationship that we have with management and other staff. And also, consults are being sent to us, which is also a sign of acceptance. On our electronic health records, we also have full access to patient information, which is also part of the level of acceptance. Then, like I said, 15 consultants out of 15, which is 100%. Then we are still improving. We are still working towards a point where we will have pharma-med consultant clinics that will just come strictly to see the pharmacists. That's where we are heading. This is a copy of one of the consults that was sent to us to assess a patient for possible TPN. This is an example of the TPN bag we used. Then in conclusion, I want to tell us that pharmacy department as a center of excellence in FMC Asaba is consistently involved in rendering high quality pharmaceutical care services to our patients. This has been made possible through the instrumentality of highly seasoned and trained professional pharmacists that we have, and the department is constantly being repositioned to meet the evolving trends of the profession through training of staff, maintenance of standards in line with global best practices. Thank you for investing your time with me.
Thank you, FMC Asaba. We'll take a brief interlude. Music interlude, please.
It's the world's greatest, Joe. It's the world's greatest. Come on. Yeah. The world's greatest. I am a mountain. I am a tall tree. Oh, I am a swift wind sweeping the country. I am a river down in the valley. Oh, I am a vision, and I can see clearly. If anybody asks you who I am, just stand up tall, look them in the face and say, I'm that star up in the sky, I'm that mountain peak up high. Hey, I made it, I'm the world's greatest. And I'm that little bit of hope. When my back's against the ropes, I can feel it. I'm the world's greatest. The world's greatest, Joe. The world's greatest. Ever. I am a giant. I am an eagle. Oh, I am a lion down in the jungle. I am a marching band. I am the people. Oh, I am a helping hand. I am a hero. If anybody asks you who I am, just stand up tall, look them in the face and say, I'm that star up in the sky, I'm that mountain peak up high. Hey, I made it. I'm the world's greatest.
So we are calling on the third presenter, Pharmacist Aduku Joseph from National Hospital, Abuja.
Yes. Good morning, Chairman and the House. Permit me to stand on the already established protocol. I am Joseph Ojochide Aduku. I'll be taking you on a virtual walk through Pharmacy Department, National Hospital, Abuja. So here is my outline. National Hospital is an over 500-bed capacity hospital rendering specialist services in all areas of healthcare. We are a teaching center, and we are also a research center. And it has the only national trauma center in the country. It's a national center of excellence for oncology. And pharmacy is decentralized into 21 satellite units, including nuclear pharmacy, oncology pharmacy, production pharmacy, compounding, drug information service, pharmacovigilance, amongst many others. Pharmacy Department National Hospital has 111 staff strength, 53 registered pharmacists, and 37 interns, amongst other support staff. It's headed by a consultant pharmacist. And the department has 18 fellows of the college. Even though we've trained well over 40 fellows of the college, currently we have 18 fellows. And I have a cheering news. The National Hospital has joined the ever-increasing list of institutions that have implemented consultant pharmacist cadre. So here are some of our pharmacists carrying out various activities within the hospital. In Pharmacy Department National Hospital, we have a mission to provide drug responsibly to patients. And because of the high premium we place on pharmaceutical care in National Hospital, besides the pharmaceutical care activities carried out by other pharmacists within the hospital, we have a dedicated unit for clinical ward round, which has a staff strength of 12, headed by a clinical pharmacist who is an assistant director. This unit carries out pharmaceutical care activities, on daily basis in the wards, and have made a lot of life-saving interventions. And these interventions have been documented in the AHAP standardized clinical intervention form. As you can see here, worthy of mention was a case of a patient, a 6-year-old girl who was being managed for sepsis. And the doctor prescribed procaine penicillin IV, 600 units every 6 hours. And we know as pharmacists, procaine penicillin is not given IV, it is given IM, never IV. Because when given IV, it causes an acute pulmonary embolism, which causes respiratory collapse. And when our team intercepted this, the doctor was contacted immediately. And she admitted that she intended to write crystalline penicillin and not procaine penicillin. She thanked our team. Death was averted because the patient would have gone as soon as administration of that drug was made. There are a lot of those critical interventions we have made, but time will not permit me to mention them here. And some of these interventions are brought into clinical meetings on Tuesdays where they are being reviewed. They are also presented at the hospital ground rounds where they are being reviewed. And the interventions are documented on our own documentation form, which is clinical medication reconciliation report, as well as the AHAP standardized clinical intervention report. We have a drug information service very well equipped and active 24 hours in a day. And it provides drug information to patients and other healthcare practitioners. We have a dedicated helpline where we can be reached at any time. And then the Drug Information Center produces quarterly drug information bulletin, which is circulated around the hospitals. And the unit also organizes Tuesday clinical meetings, as evidenced by our schedule of presentation. And the slide you can see our colleagues making presentation. And National Hospital Pharmacy also was designated by the Federal Ministry of Health as a National Poison Control and Information Center. We manage poison cases from within and outside Abuja. And we have an active pharmacovigilance unit, which is responsible for documentation of adverse drug reactions, reporting to NAFDAC. We fill the yellow forms, and we also utilize the Med App Safe where we fill online to ensure that information are not lost. It's not lost. We have an active drug and therapeutic committee, and we have pharmacists as members, as evidenced by the letter of nomination displayed on the slide, and our pharmacists making a presentation at drug and therapeutic committee meeting. This is our compounding and mini manufacturing, and we compound a wide range of products from extemporaneous preparation through total parenteral nutrition, through hypertonic and hypotonic salines, and then we also make hand sanitizers and a lot of other products. These are some of the products we make in National Hospital. And these products are not used only within the hospital communities, as we produce also on request to other institutions. Recently, we've made for Ministry of Niger Delta Affairs, NYSC, United Nations, US embassies. You know, quite a lot of institutions come on request and we make for them. And we also compound for other institutions like Noma Center. We can handle all of their compoundings for them. And this is a chart showing the rate of compounding of various preparations from January to December 2024. And it's showing that non-sterile oral preparations had always taken the lead for most of the months. And we have 4 dedicated stores that carries out inventory control and management. Worthy of mention is a North Central Zonal Narcotics store, which is domiciled with us, and I am the focal pharmacist for that. We store and issue Schedule 1 narcotic medicines to all the hospitals within the North Central geopolitical zones. And we also provide supportive supervision training for all the pharmacists that stock these products within the North Central zone. And here is our store. We have a walk-in cold room for storage of our temolabis. We are a national center of excellence for oncology pharmacy practice. And it is little wonder that one of our pharmacists has been given Oncology Pharmacist of the Year for his pharmaceutical care contributions in recent time. Here are some of our pharmacists, oncology pharmacists, ably led by the consultant oncology pharmacist Adeshola Clara, who is our HOD, and then pharmacists carrying out reconstitution using laminar flow to prevent infection. And one of the emerging fields of pharmacy practice is a nuclear or radio pharmacy. And we have a nuclear pharmacy department. We have staff who are trained and well equipped in this unit. You can see one of our staff carrying out his duties at the radio pharmacy department. And we are a member of many multidisciplinary committees in the hospital, and some of which include the Drug and Therapeutic Committee I've mentioned, Antimicrobial Stewardship, Pharmacovigilance. Some of these committees are headed by pharmacists. Here are some of our pharmacists. We collaborate with nurses, with doctors, and other healthcare practitioners within the hospital. And we are also a member of the robust hospital ground round. We've made a lot of presentations, clinical cases, at different times, very recently on adverse drug reactions and other topics as shown on the slide. Then we collaborate with other institutions. Very recently, we collaborated with AHAPEN Incorporation in hosting the 2025 Nutrition Conference, which was a huge success. And then we interfaced and also collaborated with the WAPCP executives. Our services are well recognized in National Hospital, and so letter of commendations as displayed has been given to several of our staff. And we train other staff and in other areas of pharmacy practices like oncology pharmacy as evidenced on the slide. And for research, we are very, very passionate about research. One of our research was presented at an international symposium, by our HOD pharmacist, Adeshola Clara. We have published a lot of our researches in both local and international journal, Daraka et al. In the Nigerian Journal of Pharmacy, Okonkwo et al. In the International Journal of Infectious Diseases. And we also carry out our waste management in collaboration with NAFDAC. Then we have carried out a lot of advocacies. We believe in giving back to the society. We have carried out medical outreaches in environments around us. And we have carried out advocacies also to schools within Abuja, as evidenced on the slide. We have also participated in celebrating World Disease and Days. We celebrated World Pharmacist Day with our CMD and CMD of Ibindino University Teaching Hospital, and then celebrate our interns. Then we celebrate end of the year party. Thank you for listening.
Thank you. Thank you very much. We are calling on the next presenter from University of Uyo Teaching Hospital, Farm F. Young.
Good morning, Mr. Chairman, and everyone in the house. My name is Pharmacist Nsika Kifio. I'm a consultant pharmacist standing here to present the group dynamics for University of Uyo Teaching Hospital. Right. Now that's a disclaimer. Information is believed to be true, presented in good faith, and is not intended to be used as a means of litigation against University of Uyo Teaching Hospital. My objective this morning is to highlight on the impact of effective delegation through organizational structure for effective provision of pharmacists care services at the hospital, as well as highlighting on how teamwork and collaboration among healthcare professionals have helped us improve patient safety and quality of life. That's my outline. That's our teaching hospital came into being 2008 following series of transition, and then that's our head of our chief medical director. The University of Uyo is a 500-bed tertiary institution, and then we have been transited from specialist hospital to federal to the University of Uyo Teaching Hospital in 2008. At the core of our mission is to provide health care services and manpower development in a compassionate and dignified manner. Vision statement is to become an excellence of a center of excellence regionally, and then promote the research and training of health manpower development. Pharmacy department at UTH had also transited over the years. We were formerly practicing a centralized dispensing unit, but with transformation, we were upgraded and on upgrading. We have now embraced the decentralization pharmacy practice. And of course, we know that decentralization aims at improving patient safety, improving outcome, and optimizing efficiency. That is our head of department, who is sitting atop of 128 staff. Now, this is the organogram, the point I'm trying to raise here. How structural organogram has helped us in delivering pharmaceutical services effectively. At the top is the HOD. We have a 5 division, namely admin and human resources. We have clinical and ethics, pharmacy ethics. We have education, training and research, production and quality control unit, as well as the public health unit. Blue stands for the different units. At the Teaching Hospital, University of Uyo, we have about 16 units, 14 within and 2 outposts outstation. We also have a drug information center at the core of it. Now, those are the different acronyms we have used, GOPD and all of that, 16 of them in number. Our focus in on the divisional activities, how it has helped us improve pharmaceutical care practice. At the top of it is education, training, and research. We nickname it ETR. ETR is tasked with the supervision of training of interns and students as pharmacist extenders. They help us in continuous education of pharmacists. They also help in supervision of specialty training, including those from the postgraduate college of pharmacies and those undergoing postgraduate studies in the university. At the top of it is our delectable Dr. Ikwema Basietai, who is a consultant pharmacist and the head of that team. Picture don't tell lies. This is an example of our training. That training is undertaken by an associate professor. We invite them from time to time. From time to time, we anchor it, and that is a kind of training we embarked on. This training happens every Wednesday between the hours of 8:30 to 10:30 a.m. Our clinical division is tasked with the definition of core clinical activities, medication safety and rational use of drugs. They coordinate the pharmacist ward round as well as the grand rounds of the hospital. Pharmacy department have severally and intensively been involved in grand rounds presentation, and our grand round presentation have been worthy of note. We have taken something on adverse reaction on global impact of decentralization of pharmacy practice, to mention but a few. At top of that division is Dr. James. She's a consultant pharmacist. And then these are some of our ward round activities which we embarked on every Tuesday between the hours of 8:30 to 10:30. This is actually done in at pediatric ward round. The structure of our clinical ward round is that we structure ourselves into 4 units to go in sync with the 4 major divisions of medical practice of obs and gynecology, medical, surgery, as well as the pediatrics. That is a picture representation of our ward round. That's another ward round that was led by one of our consultants, and that's yet another one. Now, we also try to harmonize our practice by the introduction of standard operating procedures, which is placed in every unit. Public health helps in awareness and enlightenment on disease immunization and public health enlightenment. At top of it is Dr. Arebi, an a consultant pharmacist. We produce e-flyers that help to educate people on World Health Days and other things of this thing. That was an outreach that we undertake to a secondary school on Drug Abuse Day. Our colleagues at the radio station. Administratively, we manage the personnel of the hospital, help in conflict resolution in line with the PSR, as well as drug procurement and policy implementation. That is the head of the division. And then our team is made up of 49 registered pharmacists. As listed there, 7 of us are consultant pharmacists and fellows, 11 fellows of the postgraduate college. Quality control is saddled with compounding and other things as shown in the picture. I am the one sitting at top of that department, that division as the head. And here is some of our production. That's antibacterial hand wash. We have antiseptic solution and germicide. Of course, we do not produce just for the hospital. We produce for the ancillary hospital around us and on request to the NYHC centers too. We are also involved in production of drugs. That is one of our production stations. Now, we collaborate with healthcare professionals to bring home some of the intervention that I've talked about here. These are myself talking with one of the nurses in one of our routine ward rounds. We have documented some of this intervention, well over 1,000 of them, but suffice it to say that we have a few to present here because of time constraint. But you allow me to talk about this particular one, a 2-year, 1-month-old baby who was weighing 13.4 kg, prescribed syrup, cefuroxime at that dose. After a consultation, we find out that that dose was too low because cefuroxime is given at a dose of 20 to 30 milligrams per kilogram body weight in 2 divided doses. So the prescriber was contacted and the right thing was done. The patient was given 201 milligrams 12 hourly for 10 days, which transmitted to 8 meals of a 125 milligram per 5 meals this thing. That's still part of it. Because of time, we'll not be able to talk about it. These are model of a pharmacy unit. That's the GOPD pharmacy unit. And all our pharmacy unit is supposedly to be like that. Then that's our counseling unit. And then we look at what are our recent innovation in line with the discussion of today. We've been able to provide medication basket born out of the fact that when you go to the ward, sometimes the medication of patients are scattered. So we provided the medication basket, medication chart. We have also added the reconstitution of 3% normal saline, production of chloral hydrate, as well as morphine solution for pain patient. That is an example of what our medication basket looks like. The purple is for the pediatrics, the blue for the male medical, and then the lemon for the male medical. These are some of our innovations that we have made. And then what are our challenges? Inadequate space is still a challenge. We hope to overcome it. And of course, some prescription diversion, which we have worked through that by way of having e-dispensing. Then our future is to have a present intensive care units, become part of the oncology units, and then have presence in this ward 247 as ward-based pharmacies. Our conclusion is that over the years we have transmitted from being a centralized system to decentralized system. Our collaboration with healthcare professionals has successfully resolved many drug therapy problems. The department no doubt faced with some challenges of inadequate space, but our intention is to expand to critical care area. Thank you very much.
Thank you, University of Uyo Teaching Hospital.
colors of a rainbow, and I can feel the sun on my face. I see the light at the end of the tunnel, and I can feel heaven in this place.
So, the next presenter from Federal Medical Center, Yenegua.
Good morning, distinguished pharmacists of our noble profession. I would like to stand on already established protocols. I am pharmacist Adigio Margaret Ebinabo, representing Federal Medical Center, Yenegua, Bayelsa State. Here is our table of contents. About us, who are we? We are Federal Medical Center, Yenegua, and we provide comprehensive tertiary healthcare with advanced technology. We have a skilled team also. And also we have an annex in Otweke, Ogbia local government area in Bayelsa State that services the Federal University and its environs. And who are we as pharmacists in Federal Medical Center in Yenegua? We are go-getters, we are achievers, and we are the 10-star pharmacists. This unique ability has availed us the opportunity of winning an award as the best department in Federal Medical Center when it comes to service delivery. Our vision is to serve mankind to the very best of our ability and capability through the provision of pharmaceutical services. And our mission also is we exist to serve mankind, especially the clients and patients that come to us to seek healthcare in our center. These are our department structure, and we are headed by our head of department, who is also our director of pharmaceutical services. Then these are our organogram, headed by our Director of Pharmaceutical Services. Our staff strength is made up of 134, and which comprises of 68 residents, 2 core member pharmacists, and 13 interns, one of which was a pharmacist technician that was encouraged and supported to go to pharmacy school. Then we have 51 support staff. Our core team, we have Director of Pharmacy, our Deputy and Assistant Director, the Principal, Senior Pharmacist, and we also have interns. We also have support. We are supported by our Principal and Senior Technicians, store, clerical, and scientific officers. Then as a result of us being a 10-star pharmacist, we encourage personal development, and we are lifelong learners. So we have 2 PhD holders, 6 PhD in view, 19 fellows of the West African Postgraduate College of Pharmacy, and we have 13 PhD MSc holders. We have 12 PharmD holders and 3 pharmacy technicians in training as pharmacists. They're in their final year now. Then our department is highly decentralized, as you can see. Worthy of note is our public health pharmacy that houses the South-South Zonal Narcotics Store and the other units, as you can see. Then we have our drug compounding and production units. Over the past 1 year, from the month of June 2024 to July 2025, we have been able to produce 1,126 drugs, and we have an average of 80 drugs compounded monthly. This is a pictorial view of our compounding units and the activities that are being carried in there. Then we have our drug information units. How do we provide information? Through thrice weekly pharmacist-led ward rounds, which has led to a lot of pharmaceutical interventions. As you can see, we have a sample of that also. We have our drug therapeutic committee that is ably led by our Director of Pharmaceutical Services, and other members are drawn from clinical departments. This committee has been able to produce our hospital drug formulary. As you can see the samples there. Okay, we have our pharmacovigilance committee also, that is ably led by our Director of Pharmaceutical Service also. And these are samples of completed NAFDAC yellow form of adverse drug reactions. As teachers, as 10 staff pharmacists, we are also teachers, and we are consistently involved in training of our students and interns as they come in for training. And also, presently, we have some pharmacy technician students on IT. This is a pictorial view of our monthly ground round presentation by each satellite pharmacy unit. Also, as researchers, we've been able to do several researches, and there's an ongoing research, a collaborative research, on comparing the efficacy of different ACT combinations and the rates of treatment failure of patients receiving ART in 2 health facilities in Bayelsa State. This is also under our training and clinical activities. We have an average of 6 case study review weekly for inpatients across different satellite pharmacies, and we've had over 600 case presentations for the past 1 year. So these are samples of our case presentations. And we had the drug therapy problem of irregular medication intake, which risked treatment failure and increased side effects of polypharmacy. So we intervened, and there was improvement and stability. Although there was financial constraint and delayed lab results, which would impact on the overall, but at least we intervened and there was improvement. Then the pharmaceutical activities will also carry out antibiotic stewardship, formulation and drug delivery, therapeutic drug monitoring, and pharmacovigilance. Very active in our facilities. Then our unique activities. We have a certified oncology pharmacist in our facility, and also our assisted and reproductive health pharmacy is very functional, and we have 25% success rate in that pharmacy, in the activities carried out there. Then also, we carry out community health sensitization. That is, we collaborate with other professionals in our facilities. Like every year on World Cancer Day, we collaborate with other professionals in our facilities and go on sensitizations. Then, the one that is ongoing now is our collaborative work with Bayelsa State Drug Abuse Prevention and Rehabilitation Committee. We carry out sensitization on the negative effects of drug and substance abuse. We've gone on the radio, we went on roadwork also, and we also visit school, which is still ongoing. Those are activities and many others that we carry out. Okay, this is a picture gallery of most of our activities, and that's the A&E pharmacy, the oncology pharmacist, the store, and other. So the next slide will be a short clip on most of our activities carried out in the facility.
Pause. Her time, please.
We are the dreamers, we make it happen. Guess we believe it. Look who we are the dreamers, we make it happen. Guess we can see it. It's to the ones that keep the passion, respect. Oh yeah, it's to the ones that can imagine, respect. Oh yeah.
Thank you, FMC Bayelsa. We would like to call on the last presenter.
The last presenter, University of Ilorin Teaching Hospital.
Standing on the existing protocol, I want to greet everyone good morning.
I can see the colors of a rainbow, and I can feel the sun on my face. I see the light at the end of the tunnel, and I can feel heaven in this place, and that's the sign of a victory. That's a sign of a victory. I can feel the spirit of the nations, and I can feel my wings riding the wind. Yeah, I see the finish line just up ahead now, and I can feel it rising deep within, and that's the sign of a victory. That's the sign of a victory. Now I can see the distance of your journey, and how you fought with all your might. You open your eyes to global warming, and through it all, you sacrificed your life. That's the sign of a victory. Yeah, yeah. That's the sign of a victory. If we believe we can achieve anything, including the impossible, this I know. So let's lift up our heads, yeah, and raise the flag, yeah, yeah. Scream like you're born to win. Now let the games begin. That's the sign of a victory. Yeah. That's the sign of a victory. Yeah. Yeah. That's the sign of a victory. Oh, oh, oh. That's the sign of a victory. Yeah. When you keep on fighting, after you lost your strength, that's the sign of a victory. Yes, it is. And when darkness is all around you, you still find your way. That's the sign of a victory. Oh, you got the victory. Say, come on and sing. Lift up your voice and sing. Oh, stand up, come together, stand up, come together. It's the sign of a victory. Oh, that's the sign of a victory.
Standing on the existing protocol, I want to greet everyone good morning. And my name is Rashid Muhyiddin Abidemi, a fellow of the college. And the next few minutes, I'm going to be taking us through our activities in pharmacy department, University of Ilorin Teaching Hospital, I'm also going to be taking us through our capacities and pictorial evidence to such effects. Introduction. University of Ilorin Teaching Hospital is a tertiary institution which is located in north central of the Nigeria, and it has almost 1,000 bed capacity with more than 5 satellite clinics being managed by the hospital. It has an actively functioning pharmacy department with track record of excellent service over the years. This is the picture of the main gates. Structure of the pharmacy department in the hospital. The pharmacy department in the hospital adopt a decentralized model with 24 units. We have a total number of 61 pharmacists in the hospital. 35 residents are 35 of them are resident pharmacists. We have 3 corpers, and presently we have 23 interns. Out of the resident pharmacists, we have 10 of them which are fellows of the college, and 8 have been appointed as consultant pharmacists by the hospital management. This is the picture of our pharmacy complex in the hospital. The pharmacy units in the hospital is categorized for easy classification into 6. Inpatient units, which are A&E pharmacy, inpatient pharmacy, oncology pharmacy, O&G, ICU. Outpatient pharmacy, which are main pharmacy, GOPD, VIP pharmacy, behavioral pharmacy, arts and dots, and NHIS. We have mini production units, which is compounding pharmacy in the hospital. Then we have drug therapy monitoring and information, which comprises of 3 units. Ambulatory care pharmacy, which is just of recent established. DIU, we also have pharmacovigilance units under drug therapy monitoring and information units. Then we have drugstore, 4 drugstores. One is EDRF, the other is ECRF. Then we have OPRF and the NHIS store. These satellite pharmacies are not located inside the hospital. They are outstation, being managed by the hospital. We have more than 5 of them. ACE, IEMA, and other ones. So this is the number of pharmacies and breakdown of the ACADA accordingly. We have presently in the hospital, we have 3 DPS, 14 DDPS, 9 ADPS, 2 chief pharmacists, 7 principal pharmacists, 3 pharmacists 1, 3 corper pharmacists, 23 intern pharmacists. So this is the breakdown of pharmacists with postgraduate qualification. We have 10 PCP fellows, out of which 8 has been appointed as consultant pharmacists by the hospital management. 2 pharmacists are currently having their program with the WAPCP. We have 1 PhD holder in the person of our HOD, pharmacist Dr. Grace Medubi. Then we have also 1 pharmacist who is currently doing his PhD program. We have 7 MSc holder in the pharmacy department. We have 1 person still undergoing the program, 1 MSc in field, and you have 5 PharmD holders. So this is the picture of some of our pharmacists while discharging their duty professionally. Compounding unit is a specialized unit in the pharmacy department starts with preparation of extemporaneous preparation. But in addition to this, it is also involved in mini drug productions. So these are some of our products that we produce for the hospital. Normal saline for wound dressing, sulfur-salicylic acid ointment, syrup, paracetamol. This picture shows is taking why paracetamol syrup is being prepared. These are our pharmacists fully kitted during paracetamol preparation. This is during the production of sulfur-salicylic acid ointment. These are some of our products. Oncology pharmacy is in the hospital is a fully functioning special pharmacy for oncology patients. But at the same time, it's also involved in compounding oncology drugs for patients that need IV medications, such as IV doxorubicin or cyclophosphamide. It is equipped with most recent state-of-the-art biosafety cabinets. So this picture shows one of our oncology pharmacists working with biosafety cabinets fully kitted up. Drug information unit in the hospital is very active, and we provide active and passive services. Active services include clinical presentation, health talk on rational use of drug, and drug information query, responding to drug information query. As a matter of fact, we have a toll line. This is the toll line for any patient that need drug information from the pharmacy department. So it's also involved actively in drug therapeutic committee, and we have two of our pharmacists who are members of the committee in the hospital. So this is the pictorial evidence of one of the health talk by DIU, awareness lecture during World Malaria Day, indicating some of our pharmacists that took place this year. That's our HOD. We have pharmacovigilance office, which is very, very functioning. And as a matter of fact, it is the Sona pharmacovigilance office throughout the North Central. It is headed by a consultant pharmacist special grade 1, and the unit monitors and documents adverse drug reaction for timely intervention. It also creates awareness locally and beyond on medication safety. So between 2020 and 2025, 83 ADR cases were reported cutting across ages 0 to 60 years and occurring in both male and female. And while frequency distribution was taken, it was discovered that the most drug implicated during the reports were anti-cancer drug, antibacterial, other were antihypertensive, and other ones. And organs mostly affected were skin, CNS, and GIT. 85% of the cases reported were fully recovered after proper intervention from the pharmacovigilance office. We also work with the NAFDAC too. So these are some cases of ADR reported. It's a case of toxic epidermal necrosis. The picture below, this picture was taken during pharmacovigilance training. This is the head of the unit and others during the training. The head of the unit is the one giving the lecture at the top picture there. Training and research, as we all know that University of Ilorin is a teaching hospital, so it is expected of us to also engage in researches. And in the department, so far, we have been able to carry out 20 researches, out of which 8 were published in critically acclaimed local and international journals. The most recent one is titled Prescription Pattern of Anti-Malaria Drug for Pregnant Women Attending Antenatal Clinic in UITH, authored by my humble self and one of our Oga, and it was published by WAPCB Journal in 2025. Clinical meetings take place every Tuesday of the week. So this is the pictorial evidence of clinical meetings. We also engage in pharmaceutical care activities. 9 pharmacists in the pharmacy department are in the ward, and they are totally accepted by the management. We also engage in pharmacy ward round. We engage in grand round in the hospital. We do treatment review, and a unit has been set up to fully face this. It is called ambulatory care pharmacy. Between January 2024, when the unit was set up, till June 2025, 58 cases of drug therapy problem have been documented, and proper intervention has been taken on them. So this is one of our pharmacists counseling a patient on polypharmacy down there at ambulatory care pharmacy in the hospital. So this is extract from improvised PC record in the ambulatory care pharmacies where we do our pharmaceutical care. In all settings, there are always challenges. So that's why limited resources and few other challenges we are facing in University of Ilorin Teaching Hospital. Clinical pharmacy practice in UITH is still
Time
is
up.
attaining a remarkable feat,
Time up.
as evidenced by the.
Time up.
So, thank you very much.
Thank you to our dear presenter. Please, can we put our hands together for our presenters? Please, a quick announcement before we move to the secondary category. The hall is too noisy, please. The hall is too noisy, please. It's becoming a point of distraction. We'll inform them, but at least let's contain the noise from here so that we can tell them to. If we are noisy here, how can we tell them that they are distracting us? So please, let's reduce the noise. On that note, we want to thank our presenters representing tertiary hospitals. Please put your hands together for them. We'll still call you. Just sit down, we'll call you again. For snap. No, just sit down, we'll call you. They've done well. They've done well. It's not easy presenting. It's when you're holding this mic and standing there that you understand what these people have gone through. At times, the thing will be projecting and you would have forgotten what you're talking about. So they've done well. They've done well. So we'll call on the secondary category.
Okay, the secondary institutions. General Hospital Ikorodu. Please, can you come forward? Pharmacists, Fagbenro, Rodiat. General Hospital, Kubwa, Abuja. Pharmacist, Ranat, Onune. General Hospital, Mina. Pharmacist, Fatima, Adamu.
Just for our presenters, please tell us what is necessary so that I can get points. Tell us what is necessary. Don't go about beating around the bush. Speak to the necessary points, please, so that I can get your points. Thank you. We'll call on the representative of General Hospital Ikorodu to take her presentation. Please, 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 let's reduce the noise. Let's reduce the noise so that she will not get distracted, please. Thank you. Your time starts now.
Good morning, my fellow colleagues. All protocols duly observed, and pharmacist Fagbenro Rodiat, a fellow of Postgraduate College of Pharmacists. I'm presenting to you Pharmaceutical Care Services at General Hospital Ikorodu, Lagos. These are my outline. Introduction, structure of department, pharmaceutical care activities in the pharmacy department and the hospital, as listed below, research and awards, and challenges of the department. Introduction. General Hospital Ikorodu is a secondary health facility with 265 bed capacity. It was established in 1950 as an area called Agbala and presently located on TOS Benson Road, Ikorodu, Lagos. It's a multi-specialist hospital with range of services, and we have a staff strength of about 700. It serves as a training center for healthcare professionals and students on CWES. Our vision is taking healthcare service to the Senate, while our mission is to provide affordable, effective, and efficient service to the people of Ikorodu and its environs in a patient-friendly environment. While our core values are 3 P's: professionalism, patient-friendliness, and promptness. General Hospital Ikorodu is headed by Dr. Taiwo Hassan. General Hospital Ikorodu Pharmacy Department is led by CZ Martins. Is a fellow of Postgraduate College of Pharmacists and Distinguished Service Awardee. These are structures of the GH Ikorodu Pharmacy Department. It is decentralized into 8 units within the hospital and 2 annexes outside. We have a staff strength which is listed below. We have a staff strength of 46, 23 pharmacists, including 4 fellows. In addition, 1 corporate pharmacist, 7 intern pharmacists, and 4 pharmacy students on CWES, and 23 pharmacy technicians. Our organogram in the department. Our director, HOD, is a director of pharmacy. The next, we have 2 deputy directors, 2 assistant deputy directors. We have 1 principal pharmacist, 2 chief pharmacists, and others are grade 1 pharmacists. That's the front stage look of our pharmacy department and some of our pharmacists and the fellows in the house. Pharmacy department subunits. We have pharmacy store, accidents and emergency pharmacy, medical outpatient pharmacy, national health insurance pharmacy, main pharmacy, which is general outpatient pharmacy department, Lashman pharmacy, that's Lagos State Health Management Agency pharmacies, also known as Ilere Eko. We have rehabilitation center pharmacy, house-to-house pharmacy, antidote pharmacy, and maternal and child care pharmacy unit. Now, pharmacy care activities in the pharmacy department. First, and hospital. The first office is compounding and production units. In this department, in this unit, our pharmacists prepare extemporaneous preparation for customized dosage forms that are not readily available in market, and for patients that have difficulty in swallowing, dysphagia, and also for pediatric patients to encourage palatability to improve adherence. An example of frequently compounded preparations are sodium valproate, levofloxacin, carbamazepine, propranolol, and furosemide, etc. We also produce liquid hand wash, antimicrobial hand wash, 75% alcohol-based hand sanitizer, and 3.5 sodium hypochlorite. We also produce, these are pharmacy department subunits. Now, counseling and drug information. Our pharmacists provide patient medical information, advice, and support to patients just to improve their understanding of their health condition and treatment plan in a private, safe, and comfortable space. Our pharmacists also educate healthcare professionals through different interventions. Our pharmacists educate patients through counseling and health talk, and also public during our awareness campaign on radio stations, both English and Yoruba speaking, on medication and on medical issues. Our pharmacists do prepare and compile drug bulletin bi-monthly. Our pharmacists also give notification or alert on any medication, give NAFDAC alert on any medications to other healthcare team. Pamphlets and leaflets are made available during our awareness campaign. This is the picture of our health talk in one of the waiting areas in the hospital and our radio station. These are the pharmacy intervention or treatment review we had, any error that's been detected, pharmacists do write a short note to the physician or through physical contacts, and the patient will be reviewed. And the reason for this review is either to do dosage modification, substitution, or discontinuation, or due to pharmacoeconomic reason. Example of our intervention: 2 musculoskeletal relaxants was prescribed by a physician. The pharmacy did the intervention, and the patient was reviewed. That's one of our medication follow-up too we use in documentation. Word round is carried out weekly, and the aim is to identify drug therapy problem. Our documentation tools that are being used are intervention form, pharmaceutical care report sheets, and pharmacy word notes. That's what our word round review. And the topic treated is subclinical presentation. There is online consumer medication by Lagos State Ministry of Health and Health Service Commission. The trading issue take precedence. Monthly rosters are in place, as shown on the screen. That's our pharmacovigilance activities. We do detect adverse drug reaction during ward round, patient counseling, and websites. The gentleman shown on the screen reacted to ciprofloxacin, and that's the documentation. The case was followed up. The necessary follow-up was taken. This shows our collaboration with other healthcare teams. Drug Therapy Committee, Emergency Trade Committee, Infection and Prevention Control Committee, National Parental Death Surveillance Review Committee, Pharmacovigilance Quality Improvements and Safety Committee, in which the pharmacists take active role. This is a research conducted by GH Pharmacists at the General Hospital Ikorodu. The title of the published research is a comparative evaluation of fixed dose administered combination of lisinopril and adocostats in treatment-naive adults and hypertensive in a rural Nigerian community. Ungoshere, ITA, 2022. And there's ongoing research, medication prescribing pattern in patients with preeclampsia and acinar tachyny. These are the awards won by the members of the department, and thanks for listening.
Thank you very much. Thank you. So our second presenter.
The panel of judges, distinguished pharmacists here present, good morning. I'm pharmacist Rahanat Al-Hassan from Kubwa General Hospital. I'll be taking you through the pharmaceutical care activities in Kubwa General Hospital using this outline. Kubwa General Hospital is a secondary healthcare facility managed by the FCT Hospitals Management Board. It is located at Phase 4, Kubwa, a satellite town in FCT. It was commissioned first as a health center in 1990 and was later upgraded to General Hospital in 1992. Currently, it has a 130-bed capacity and offers comprehensive medical services to about 10,000 patients averagely per month. Services rendered in the hospital include pharmaceutical care services and specialized medical services like ENT, ophthalmology, urology, general surgery, internal medicine, nutrition and dietetics, and the rest. The pharmacy department of the hospital is housed by a stand-alone building, and it is fully decentralized into 8 different satellite pharmacy units and an annex at the FCT NYSC orientation camp. The unit is headed by a deputy director. The different satellite units include the box store, which serves as a bridge between the pharmacy department and the other hospital units. The active store serves as the bridge between the pharmacy department and the other pharmacy units. We have the GOPD pharmacy. We have the GOPD pharmacy, ARV pharmacy, O&G pharmacy, production unit pharmacy, NHIS inpatient pharmacy, we have theater pharmacy, and we have pharmaceutical care drug information and pharmacovigilance units. The The production unit pharmacy is the unit that produces cleaning agents that the whole hospital now use. These are the staff of the unit. We have currently 16 registered pharmacists, 1 locum pharmacist, 10 copper pharmacists, 10 intern pharmacists, 4 pharmacy technicians, 2 pharmacy assistants, and 1 industrial pharmacy student. Among the 16 registered pharmacists, we have 6 deputy directors, 1 assistant director, 3 chief pharmacists, 3 principal pharmacists, 1 senior pharmacist, and 2 pharmacists. We also have currently 3 fellows of the West African Postgraduate College of Pharmacists, and we have 3 members of the college that are also residents in the hospital. We have a functional compounding unit where we compound medications mostly for pediatric use. Here is a graphical representation of the number of medications compounded over the last 6-7 months. Pharmacists are fully involved in the activities of the hospital in Kubwa General Hospital. So we are present in 8 different committees. We have the DRF committee, the Drug and Therapeutic Committee, Maternal Mortality Review Committee, Pharmacovigilance, ART Switch Committee, and the rest. Training and clinical activities in the department happen through weekly clinical presentations, bi-weekly drug therapy review, and lectures which we give to interns, corpers, and IT students. We also carry out interdisciplinary training where we take our interns and ITs to other units of the hospital to learn what they do. Here is a picture of when we took them to physiotherapy and dental clinic. Then we also train corporate pharmacists at the NYSC orientation camp. Research, we've had 5 researches conducted in the pharmacy unit. We have 3 completed and 2 ongoing and practice of hypertensive patients on lifestyle and dietary modifications in a secondary healthcare facility. We hope to publish some of our researches soon. Pharmaceutical care activities happen through provision of efficacious, safe, and cost-effective medicines, through participation in grand ward rounds with other healthcare providers and pharmacists only round. These are pictures during and after ward round. These are pictures of pharmacists during clinical ward round, during therapeutic review. We have recorded over 200 clinical cases during the course of ward rounds. Our theater pharmacist is fully involved the pre, during, and post-surgical procedures, where she offers advices on proper medication use and also monitor for adverse drug reaction. These are the tools we use for our pharmaceutical care activities. We have the EMR software, we have the pharmaceutical care workbook, the intervention forms, and then we have the pharmaceutical care interventions. We have recorded over 40 of these interventions. A notable one is this: a prescription for an 11-month-old patient who was prescribed camosunate 1 to 6 instead of camosunate under 1. The pharmacist intercepted the prescription, went to meet the physician, discussed, and he admitted that it was an error. So it was resolved. So this is a graphical representation of the numbers of drug therapy problems that were resolved over the period in view. Pharmacovigilance activity in the hospital is very sound. We have 4 pharmacists as members of the pharmacovigilance committee. The chairperson and the focal person are pharmacists. We have recorded some ADRs. A notable one is this: a reaction to brown plaster metronidazole tablets. We use the yellow form to report, and then we transmit through the Med Safety app to NAFDAC. Okay, we are fully involved in health promotion activities. On a daily basis, the pharmacists go around different units of the hospital to create awareness on different health issues and proper medication use and safety. Here are some pictures showing drug awareness campaign during health talk to different units. And during most ward days, we carry out awareness campaigns on different health issues, and then we go out to the community that hosts the hospital. Here is a picture of World Malaria Day, where we carried out screening for malaria, distribution of insecticide-treated nets, and provision of intermittent preventive therapy for pregnant women. World Hypertension Day, World Diabetes Day, and we have World Day Against Drug Abuse, where we visited neighboring schools to create awareness on the dangers of drug misuse. During Med Safety Week last year, we went trying to create awareness around the hospital to other health workers and the patients inclusive, to create awareness on the importance of reporting adverse drug reaction. And then we had printable materials which we used to disseminate information. We had the newsletter and flyers. Here are the members of the Pharmacovigilance Committee during the campaign. Pharmaceutical care impact is evaluated in Kubwa General Hospital through quarterly reporting of PC activities and comprehensive analysis using different tools, and then comparing to previous quarters. Then feedback from both patients and other healthcare practitioners during ground rounds, pharmacist round, and drug therapy review. We are fully accepted by the hospital, as is evident in our presence in 8 different committees and the free and full participation in Grand World Round and Pharmacist World Round, and then amicable resolution of our interventions. Here are recognition. We've been recognized in different categories. For consecutive 3 years, we've been recognized as the most outstanding department in the hospital, an excellent center for training for pharmacy IT students by Bingham University, and most valuable secondary healthcare facility in FCT. And that's a picture of an award given to us by Savicom of the hospital. Conclusively, I will say that the pharmaceutical care activities of Kubwa General Hospital pharmacies has increased the synergistic relationship between us and the doctors, and this has led to increased health outcome of our patients. Thank you.
Thank you very much. So, the next person, now our third presenter for the day.
Okay. Good morning, distinguished colleagues, panel of judges. My name is Pharmacist Fatima Adamu. I'm presenting for General Hospital Mina, Niger State. Okay, General Hospital Mina is a secondary health facility in Niger State located in the state capital, which is Mina. It's a secondary health facility that are 540 bed space, the accident and emergency pharmacy, inpatient pharmacy, O&G, and the neonatal pharmacy. There are 33 pharmacists in General Hospital Mina, a deputy director, which is our HOD, 2 assistant directors, 2 consultant pharmacists, 4 fellows of the West African Postgraduate College of Pharmacists, 2 resident pharmacists, 12 interns, 3 core members, and 11 pharmacists 1. It is worthy of note to say that on our way to this conference, 2 of our fellows were appointed consultant pharmacists with benefits. There's a compounding unit in the neonatal pharmacy unit with an average of 15 compounding per week, and then the compounding unit in the main pharmacy with an average of 30 compounding per week, for both oral and extemporaneous preparation. It's also worthy to note that our consultant dermatologist has certified our extemporaneous preparation to be one of the best he has ever used. This is my HOD, Pharmacist Asana Abdul, which is the Deputy Director. This is our neonatal pharmacy unit and our accident and emergency pharmacy unit located in the accident and emergency ward. This was recently opened because of the need of emergency medication for accident victims. Our training and clinical activities carried out in the department involve training of IT students, intern pharmacists, and resident pharmacists. We have intern and clinical presentation every Wednesdays and Fridays of every week, resident pharmacists presentation every Tuesday, fellow virtual presentation every Saturday, and the department has conducted an average of 3 research every month. And that's the research. We have one currently ongoing. It is being conducted by my very survey, comparative study between the effectiveness of darunavir and atazanavir-based combination in treatment of second-line HIV in General Hospital. This is a cross-section of one of our clinical presentations done Wednesdays and Thursdays. The pharmaceutical care activities we carry out in General Hospital Mina involve the use of pharmaceutical care intervention tools, which is developed by one of our first fellow in the state, our current chairman of Association of Fellow Niger State, Pharmacist Mohammed Alfa Issa. And this document has been adopted by AHAPN Niger and is being used by all secondary healthcare facilities in Niger State. We have therapeutic ward round that is being done every Tuesdays and Thursdays, where pharmacists go to the ward, review patients' medication, make contribution, make intervention for the physicians to look at. We also have patient treatment review during ward rounds and on our medical outpatient clinic days, which are Thursdays and Tuesdays. Our documentation tools we use include our pharmacy work notes, which we use for our inpatient pharmacy and pharmacy that are, and patients that are on long-term management like ARVs, HIV, and diabetes. We also have the form that we use. This is also our pharmaceutical indication form. You can see from that indication form from number 1 to 18, the different indication we use to identify drug therapy problems. We also have pharmacy intervention made, the outcomes of the intervention. This is a copy of our pharmacy notes that we use for our patients on ARC treatment. And this note has been very useful in our ARC clinic, where our patients come to the unit, to the pharmacy for therapy. We have noticed that most of the time, the patients come with comorbid conditions that are not being managed. Patients on ART medication that have hypertension that is being overlooked. This pharmacy note has been very useful, where we identify untreated indication for hypertension, we communicate to the physician, and then they make their inputs and send back to us, where we make our own contribution. This is also our pharmaceutical care register from the pharmaceutical care indicators. We tick from the key from 1 to 18, and then you can see the drug therapy problem, intervention, and the outcomes being made. Our mechanism of impact, from our assessments, clinical evaluation, plan, implementation, and documentation, and monitoring of all our activities, it has shown that patients that are visiting General Hospital Mina are not just coming to the hospital and going the same way. They are also, the quality of life are also being improved. It is also worthy to note that our intervention has been accepted by the hospital. I am standing in front of you today. I am heading the pharmacovigilance committee of General Hospital Mina, where we have made several interventions. We have documented such intervention, and we also use the yellow form and the med safety app to transmit this adverse drug reaction we encounter in our patients. Thank you very much for listening.
Thank you, General Hospital Mina, for that wonderful presentation. We're going to take the last. Please put your hands together for our presenters representing the secondary facilities. Okay. All the presentations were wonderful. It's not easy presenting. We're going to take the last category for today, which is the administrative. I'll call on the coordinator.
It's a special world that we're living in, but we treat it like we're strangers underneath the skin. Got a baby cries, and I don't feel it too, 'cause he's a part of me, just like I'm a part of you. How much longer must we stand alone together? 'Cause to live this way's a crime, and we're running out of time.
The next presenter for PCN, Pharmacist Victor Anagu. Please, can we clap for him?
The panel of judges, fellow colleagues, good morning, everyone. My name is Pharmacist Victor, and I'll be presenting on behalf of Pharmacy Council the regulatory activities of the council. The outline is as highlighted. I believe all of us know PCN, and yesterday one of our ex-presidents took time to explain the PCN Act 2022. This is the structure. You can see the head office there and the various departments, the state offices, zonal office, and of course the various units in PCN. This is the organogram, the registrar there at the center, the governing council, and all branches. For staff strengths, we have a total of 113 pharmacists. That excludes the intern, that's 70 in number currently, and 9 corporate pharmacists. We have 33 fellows, of which 19 have been appointed consultant pharmacists. Our mandate is clear to all of us and been highlighted. Our major activities is within our mandates, and I'm sure we are very conversant with the activity 2028. There we have revised our vision and mission statements. You can see them here. We have core values that include professionalism, collaboration, innovation, integrity, and quality. These are the pictures during the strategic plan development. You can see the 6 major goals there. It has to do with transforming education, training, and capacity building, transforming registration and licensing processes, transforming pharmacy practice for sustainable healthcare delivery, transforming quality standard determination, transforming inspection, monitoring, evaluation, and enforcement, and transforming communication and the stakeholders' engagement. Because of the peculiarity of the audience here, this presentation will be looking at 4 out of our numerous activities. The hospital pharmacy, drug management agency, quality assurance mechanisms, and our collaboration with NGOs. For the hospital pharmacy, the PCN Act Section 33, subsection 1 to 3, has empowered council to inspect all hospital facilities, both public and the private, and register them. When we inspect hospital, there are areas of focus. We look at the structure and organization, we look at the professional practice, of course, the logistics, and store management is not left behind. So in the hospital, we look at the organogram, the facility, the personnel competency, policies, and the rest of them. For the professional practice, pharmacovigilance is part of the areas we look at. Quality control and research, compounding, and the rest. In the sorry. What is the problem? Sorry, it's not okay. Okay. So in the areas of pharmacy, hospital inspection, a lot has been achieved. We have reviewed our compendium. You used to know it as 4-pack compendium. Now it's compendium of minimum standards. Of course, the guideline has been reviewed, and even the checklist has been reviewed. And currently we are using new ones that take cognizance of the governance in the hospital. And that has also, council has stepped up hospital inspections. This year alone, we have covered no less than 7 states, among which is this state we are in, Edo State, Ondo State, Sokoto, FCT, Nasarawa, and the rest of them. Usually it's an avenue to have strong stakeholders engagement with respect to the commissioners of health, governors. We share the findings. Part of achievement again is that our Form K has been reviewed. Now, we don't used to have, we normally have one single Form K, but currently you can see that we have up to Form K1 to 5. 1 is for hospital, 2 community, 3 distribution, 4 manufacturers, then the last one is for dangerous drug use. These are the pictures of the hospital inspections that have been undertaken this year. What's the impact? The impact is that it has strengthened the regulation framework and, of course, capacity building, and has also enhanced the professional practice. In the aspects of DMA's activities, council have done a lot. Currently, we have a publication that stipulates the minimum requirements for setting up DMA or State Drug Distribution Center. And early this year, council wrote letters to governors, commissioners of health, and other stakeholders in the states, informing them the importance of DMA and why their DMAs should be registered for those that have DMAs that are not yet registered with council. And we have done quite a lot of inspections on DMA activities. Among inspections that we have conducted this year is that of Castina, and that of Nasarawa State. So these are the pictures. You can see them there. So the achievement there is that these activities of DMA, the activities that council has done towards DMA, has stirred up awareness in establishment of DMAs in the states. Some states now are converting their central medical store into drug management agency, and of course, some are setting up framework, legal framework, to establish their DMAs. And the impact of this is that with time, we'll have access to good quality and affordable drugs. There'll be a reduction in circulation of fake and substandard medicines. It will serve as an antidote to open drug markets and in line with CWC. DMAs are to be pushed by government. CWCs are done by individual stakeholders. And of course, it will provide a regulated environment. So the next activity to look at is our quality assurance mechanisms. We have both internal and external mechanisms. For the internal mechanisms within the council, we have our 6 months periodic audits, internal audits. And we also, that's usually followed up by quality management, top management review meetings. And of course, we normally have our surveys within every 6 months, of which I know that some of us have participated. For the external quality assurance mechanism, we will continue our inspection and monitoring activities, as well as the feedback from the stakeholders, strong stakeholders engagement. And of course, we don't relent in our enforcement activities. These are some of the pictures of what I stated. So you can see the internal audit pictures there, the management review, and the stakeholders engagement. Achievements in this area of quality assurance: PCN is ISO certified. These are certificates. PCN is have been benchmarked by WHO, and we have attained maturity level 3, and it has improved regulatory processes, and our stakeholders engagement has become quite robust and stronger. Of course, there's improvements in the client satisfaction. Lastly, among our activity has to do with engagement with NGOs and partners. Section 8 of PCN Act empowers council to collaborate with relevant organization and authority involved in public health activities. And our involvement has actually, with these NGOs, has led a lot of, has impacted so much on our regulation, and we have achieved a lot. One of them is the fact that pharmacists now provide routine service data with integrated information on health services. Then again, you PCN, pharmacists in the community practice now engage in expanded family planning services, courtesy of PCN collaboration with NGOs. Of course, it has reshaped policy making, and now there is tax shifting and tax sharing, of which the pharmacists are part of this federal government policy direction. So these are the pictures of some of the NGOs who engage. Then in conclusion, PCN is committed to ensuring the assurance.
Time up.
Okay, that has been highlighted. That's the concluding message. Thank you.
Thank you.
Just a minute. Let's put our hands together for our presenter from the Pharmacy Council of Nigeria. 2 quick ones. Please, we are looking for someone that can artistically write on, that has, that can inscribe names artistically. Please, if you are in this hall, please reach out to us. Thank you. Once again, put our hands together for our presenter from PCN. We'll call on all the presenters as we hand over the mic to the chairman for his closing remarks. All presenters, please come up stage. All presenters, please come up.
Give me. Thank you very much. Can we please put our hands together for the various institutions? On behalf of AHAPN and Council, I want to appreciate all the hospitals that are presented today. We are very glad to observe that we have robust medical care practices going on in our various institutions. And that means, of course, that the purpose of our having our medical care competition is being achieved. I want to request that all the presenters that are presented today, together with the panelists, please come up for a group photograph, please. Thank you very much. Please put your hands together for them. Okay? Where's my paper? while we are waiting for them to come up, I mentioned during my opening remarks that there's a document that was produced by AHAPEN, the pharmaceutical care document has been adopted by the PSN as the benchmark for pharmaceutical care practice in Nigeria. I would like to encourage all hospitals to have a copy of this particular document. At the get-together organized by the permanent secretary to some days back, Professor Okpara was asking me about this document. Said, how far with the document? I hope it's being practiced by the various hospitals, and that we should ensure that every hospital has a copy of this document. So I want to request, Pharmacist Gilbert, you are the secretary of AHAP. I'll hand this copy over to you. I'd like to request that please, AHAP should make copies of this document available to all the states that are here, and including the ones that are presented today. Probably also let me have a copy as an evidence that you comply with this. So please, let me use my hand is over to you, okay? You produce it and must produce and send to all, or make sure all states have a copy of this.
Medication.
Are we ready for the
And our drug stock is
not
large to accommodate all the clinics in the hospital.
Including the first group.
Now
Oh, yeah.
suppresses
Okay, fine.
in hormone binding globulin. Have anti-androgens like spironolactone and finasteride for people who are trying to meetings are also areas.
No. Oh, yeah. I'm in chains, you're in chains too. Our uniforms and you are uniforms too. I'm a prisoner, you're a prisoner too, Mr. Jailer. Oh, I have fears, you have fears too. I'll die, but you self will die too. Life is beautiful, don't you think so too, Mr. Jailer? I'm talking to you.
Thank you. Thank you. Thank you so much. Can you put your hands together for them as they return back to their seats? At the beginning of the program, we established some protocol, and we have been standing on that protocol for some time. I think it's time for us to begin to run with the protocol. We have stood so long on the protocol. And so permit me to recognize the presence in our midst, some very distinguished pharmacists, the progenitors of this great association. You people call them, including myself, the living ancestors. Pharmacist Maji Issa, FPSN, we called on you at the beginning. Yes. Pharmacist, my boss, yes, he handed over to me. The man I respect so much, Pharmacist Martin Suyewole, FPSN. We recognized you at the beginning of the program. I told them you were on your way. And I also mentioned at that program that these gentlemen, they are very pharmacy passionate, and they established the basis of what is going on today. I remember when I was state chairman Delta, each time we would come for a national conference like this, Mr. Magisa was national chairman then. He was always emphasizing about peer review mechanism. And what we are doing now is actually a peer review mechanism, okay? Because it's an opportunity for various pharmacists from various institutions to come together, and then we assess their work and then ensure that they are all practicing according to standards. So we owe them a lot of gratitude. Pharmacist Oyewole, I know, yes, put your hands together for them, please. I know the role Pharmacist Oyewole played in the session of the abstracts committee, scientific abstracts committee, and since 2016, I know by God's grace, we've been having this competition for 9 years, okay, uninterrupted. Put your hands together for him and for all of us, okay? So, sir, we are very grateful for your efforts, and during my tenure, we introduced the pharmaceutical care competition, what you have just seen, and we are making progress. Thank you. So, where are the people for the oral abstracts? Okay, you are there? So we want to now continue with the second aspect of the program, which is the oral abstracts presentation. Why are we doing all of this? Is this just for presenting sake? No. Please pay attention, okay? This aspect of the presentation of the program is very, very important. The Federal Ministry of Health, hello at the back. The Federal Ministry of Health mandates all professionals, including pharmacists, to be engaged in operations research on a regular basis. Okay, so it's a requirement of the Federal Ministry of Health that pharmacy departments should engage in operations research and document your research work. So they can come in anytime and request to see the samples of what you have done, copies of what you have done. So it's in line with expectations of our employers. And it's also important that all pharmacists at every level, whether you're in tertiary or whatever, should practice, you should engage in research on a regular basis. More so now that we have the area of consultant pharmacists. The consultant pharmacists, the onus is on you to document your observations and all that, and then get them published, contribute to the body of knowledge. Okay, so what we are doing here is part of the process, and then we're also here to teach you, our colleagues, the necessary skills that you need, okay, to practice with excellence in your various hospitals. Last year, by the grace of God, I was so impressed with the level of presentation that was made, and I was then the immediate past chairman, and I made a promise that by the grace of God, as long as God helps me, I will partner with AHAP and encourage our presenters. I had the maiden edition when I had to present some little token for the best oral abstract for them to buy data and engage in their research. This year, by the grace of God, we are going a step further. So the best oral abstract will be taking home a little token of 30,000 naira for me, and the first runner-up will go home with 20,000 naira cash, and that will be made today during the dinner today. Okay. Of course, on Tuesday I announced also about the donation, the support for the editorial committee. That by the grace of God, that will start next year. The best article we also receive 30,000 naira cash, and then the first runner up with 20,000, just to encourage them to keep writing, keep publishing, so that our association can continue to grow. On that note, I want to call on the. Thank you so much for clapping. Yes. Somebody was asking me, why are you wasting your money? I said, no, it's not a waste. It's just to help our profession to grow. And he said, well, how will you raise the money? I said, if I say 1,000 every month, before August next year, I should go say 100,000 for the project. Thank you so much. I put the hands together for the association. Thank you. So who is coordinating the abstract presentation, please? Yes. Are we ready? Okay. Please take over the microphone. Thank you. Please put your hands together for him.
Thank you very much. We are still awaiting the last two presenters. They have sent in their presentation, but we have not seen them. That's pharmacist Ijoma Eze. Where is she? Okay, please come in. Then the last one, pharmacist Nura Abbas is here. Pharmacist Eze Ijoma, please sit down with them. We'll call you up. As a way of introduction, it's good to let the audience and the general members to know that in riding on the group dynamics, this aspect has two categories: the oral podium presentation, and the last aspect is the poster presentation, which the posters have been on since yesterday. So how we do it is there is assessment before the conference. So participants send in their abstracts, a team of assessors, in this case, For the oral presentation, we had the following list of pre-conference review assessors. Dr. Ole Joseph is the chairman of the team. Pharmacist Stella Onyegasi, Dr. Hussein Prince Henry, Pharmacist Modupe Oyaole, myself, Abubakar Daraka, Pharmacist Gabriel Akinlene Kunu, and Professor Wilson Aaron as advisor. These were the 7 eminent scholars that actually reviewed what we are going to hear today. So they were assessed and corrections were made so that they can present within best international practices. Then for today, the marks awarded for the pre-conference assessment was 100. So over 100, they have already been scored. That one is kept aside as like continuous assessment. So the real exam now is over 80. So the team of assessors for today are myself, Dr. Henry Prince Hussein, Pharmacist Stella Onyegasi, Pharmacist Dr. Adekoya Omobolanle Fausat, and Pharmacist Abdul Karim Ibrahim Liman. They are all seated here. I think it's good to call them so that we just welcome them as panelists. Let me start with Dr. Henry Prince Hussein from Federal Medical Center in Agua. Then Pharmacist Dr. Adekoya Omobolanle Fausat from UCH Ibadan. Then Pharmacist Abdul Karim Ibrahim Liman from Mina, Niger State. Myself from National Hospital Abuja. Then Pharmacist Stella Onyegasi, she's attending to one of the participants. She's from Federal Medical Center, Asaba. So we will have an interactive session. Before we call the participants if they are complete, the audience need to know that we are assessing them a little different from the prior to conference assessment. For the case of transparency, it's good the audience know what we are assessing them on. We will be assessing them on professional outlook, covering corporate dressing and overall coat usage. Then there will be presentation skills, covering confidence and composure, clarity and coherence, mastery of the subject matter, engagement with audience, and handling of questions. Then the other aspect is visual aids in the presentation, quality of slides, relevance of the visuals projected, and visual appeal. The other category of assessment is relevance of the study to this year's conference team or sub-team. We were very liberal. If any of the presenter aligns with the team or any of the 3 sub-teams that were presented, he earns some points. Then the other category is the contributions of the study itself in achieving standard of pharmacy practice, covering pharmaceutical care interventions, cost optimization, and value addition to processes of service delivery in Nigeria. The last but not the least, as expected, is time management, which is the only negative marker, in the sense that if you are able to present within the timeline, you earn your complete points. But when you miss that, it's a negative marker, you won't get the complete points. So how many minutes do they have? There are only 5 of them, sir. Okay, that's fine.
Please, for the group dynamics, we don't want to have issues with name and titles and all of that. So quietly meet me to my left so that give me, if you have a PharmD, so that I will know how to, write your certificate. You understand? If you have any appendage, FPSN, whatever, so that we'll know now, please come to the left. Thank you.
So at this stage, we will call our participants. The first on the list, he might not be the one that is starting first, but on this list, sorry, let me not back the stage. Pharmacist Olalekan Oluleti, he is presenting from National Hospital. The title of his work is Impact of Pharmacist-Led Innovative Intervention in Medication Adherence and Treatment Outcomes among asthmatic patients in National Hospital Abuja. Please be on the stage. The next on the list is Pharmacist Noura Zubairu Abbas from General Hospital New Bosa, Niger State. The title of his presentation is Assessment of Treatment for Patients Living with HIV/AIDS and the Use of Antiretrovirals in Secondary Healthcare Facility. Welcome. The next presenter is Dr. Amaka Ezioko from Nnamdi Azikiwe University Teaching Hospital in Nnewi, Anambra State. She is presenting on drug therapy problems intervention in a Nigeria tertiary health facility, a pilot test of acceptability by other healthcare professionals. The fourth presenter for our oral podium presentation today is pharmacist Prince O. Okiodu from Delta State Secretariat Clinic, Asaba. His title of presentation is Impact of Project Stop Hepatitis B Interventions in Delta State. The last of today's presenter is pharmacist Eze Ejoma from, which facility is she from? Okay, UBTH, University of Benin Teaching Hospital. The topic of her presentation is drug therapy problems and interventions for prescriptions outpatients within the, in diabetics patients in tertiary hospital in Benin City, Edo State. Okay, our participants are there, so I think you will be our timekeeper, please. So we will follow through and ensure timeliness. Where is the moderator? I'm just to be seated here. Okay, the second mic, I think we can give to who is the first person? Okay, HIV. Who is presenting on HIV? Is it Nasarawa State? Okay. Just let's sort out the technical issues. So let's put it on queue, then we'll just. Pharmacist Noor Abbas is going to be the first presenter. So ICT, the podium 1. 2, the first one is not available. So you are presenting for 10 minutes. So at 7 minutes, we'll notify you you have 3 minutes more. Then when it is 1 minute more, we'll give you last notice. Just hold on, let it come up, then you start. Thank you.
This is not a slide. Good morning, the panel of assessors. So good morning, the panel of assessors, distinguished colleagues. I'm by name pharmacist Noor Abbas, a fellow of the West African Postgraduate College of Pharmacists, presenting on the assessment of treatment outcomes for patients living with HIV/AIDS on tenofovir lamivudine dolutegravir regimen in a secondary healthcare facility in Niger State. So, by way of introduction, we all know that HIV/AIDS is a pandemic, has claimed. This is not the slide I sent to him.
You have to control it.
Okay, it's not the slide that I sent to him. I sent the slide to him this morning.
We have stopped the timing. You have any issue?
Yes, it's not the slide that I sent to him this morning.
Who did you send to?
It's you have.
No, the one you sent to us is the one we.
Okay, noted. So the presentation will cover the introduction, aim and objectives of the studies, statement of research problems, methodology, result, discussion, conclusion, and then recommendation. So by way of introduction, There are approximately 38 million people living with HIV/AIDS globally, with 1.7 million new infections in 2019. The WHO African region accounted for about 25.6 million of this global burden, with Nigeria accounting for about 2 million. That is about 2.1% of the global average, with Niger State having 22,468 patients living with HIV/AIDS. The tenofovir lamivudine efavirenz-based combination was initially used but stopped along the way in 2019. Most of the clients were transitioned to tenofovir lamivudine dolutegravir fixed dose combination, which was used as first-line regimen for the treatment of HIV/AIDS as recommended and supported by PEPFAR for use in priority countries including Nigeria. So TLD has progressively replaced tenofovir lamivudine efavirenz 600 mg as first-line regimen of choice since 2015 globally, but the transitioning period was between 2019 to 2020 in Nigeria. The virus suppression is categorized into 3 categories. The unsuppressed clients are those that have a viral load of greater than 1,000 copies per mil, with the suppressed client but having a detected viral load of less than 1,000 copies per mil, and then the undetectable viral load is the one that had the clients that have their viral load that is not detected by the test use. The aims of this study is to assess the efficacy of tenofovir lamivudine dolutegravir-based combination therapy on viral suppression among people living with HIV/AIDS in a secondary healthcare facility in Niger State, with the following objectives. 1, to assess the proportion of patients who achieve viral suppression after transitioning from TLE to TLD. Then to also compare the viral load suppression rates before and after transitioning, then to identify factors that were associated with viral suppression, and then lastly to assess the effect of TLD on viral suppression. So this is the statement of research problem, which we all know that despite the effectiveness of antiretroviral therapy in management of HIV/AIDS, some of the patients may require transitioning due to either treatment failure or an adverse drug reaction or availability of a new regimen or change in national policy and guideline. Then the research gap that we identified that there was a lack of comprehensive data on outcomes of patient transition from one ART regimen to the other. Transition is within the same line of regimen between the same first-line treatment. You are transitioning from an efavirenz-based to maybe dolutegravir-based, not switching from first line to second line. So, this poses a challenge to the development of evidence-based guidelines for managing treatment transition. So this highlights the need for this study and provide a clear direction for the research investigation. So the methodology used, it was a retrospective studies involving all the HIV adult clients that were on first-line antiretroviral therapy at General Hospital Kutigi in Niger State within the period of 6 years, from January 2018 to December 2023. From January 2018 to December 2019, the clients were on the tenofovir lamivudine and efavirenz-based regimen that they were transitioned to a dolutegravir-based regimen in 2020, 2021, and 2023. So the inclusion criteria was all the adult patients that were aged between 15 years and above, assessing care and treatment from the facility, and they are on first-line regimen of TLD, and those that were transitioned from TLD to TLE. The exclusion criteria were all the clients that were on second line and those with comorbidities associated with HIV and non-HIV reactive patients were excluded in the study. So the sample size, the whole population was used for convenience and for accuracy due to the small sample size of 265 clients folders that were reviewed. So we used the whole population for the studies, a census method. The ethical clearance was obtained from the hospital ethics committee. This is the clearance, the ethical approval number that was obtained from the hospital ethical committee. So the result obtained. The result generally revealed that 265 clients were reviewed. So the clients were within the range of 15 to 79 years with a mean age of 41.0.0 with plus or minus 22 as the standard deviation. So about 35% of the patients fall within the age range of 35 as seen in the slide, 45 to 54 years. So the male to female ratio was 1:1 2.4, we have more of the female client assessing care in the facility than the male clients. Then the tenofovir, lamivudine, and efavirenz was the ART regimen used as first line in 2018 and 2019, whereas tenofovir, lamivudine, dolutegravir was the regimen used on this client in 2020, 2021, and 2022. So this next table shows the level of unsuppression. As shown in the table, you can see that the total unsuppressed clients in 2018 were 20.9% of the total client, which reduced to about 14.9% of the total unsuppressed client. With the first row there signifying that male clients have more suppression than their female counterparts assessing care in the hospital while they were on TLE. So this trend reduced to about 0.4% at the end of 2023 when the data were collected. So this shows that TLD was more effective in the management of HIV and to attain viral suppression than TLE, as shown in this thing. So this study was, the result that was obtained in this study was actually in concordance with that of the outcome that was noted in a study in southern Nigeria by Ogbogu in 2021, and which was significantly higher than similar studies that were conducted in southeastern Nigeria of 75.4% and in other countries like Nepal and China. So the result generally revealed that the viral load of clients with unsuppressed viral load before transitioning from TLE to TLD were suppressed. And it was also observed that in 2020, there were a higher number of unsuppressed clients, and this was actually due to more adherence and reduced or zero adverse drug reaction effect of dolutegravir. So this led to more compliance and more adherence by the patients. So in conclusion, the level of viral suppression among people living with HIV/AIDS in a secondary health facility was assessed, and it revealed that TLD was more effective in the management of HIV infection than previously administered regimens. So this underscored the need for continuous monitoring and regular review of the outcomes of antiretroviral therapies amongst patients. So the result of the study may be useful to policy makers, researchers, and healthcare practitioners. So these are some of the recommendations for the studies, and these were my references, the references that were used. So thank you very much for listening.
Thank you very much. Because of the aspect of assessing him on handling questions, it's important we will take one question from the audience just for him to respond. It's important. Anybody that has any question for him, if not, the panelists will have to ask him a question. Any question on his? None? Okay. Please, Dr. Harry, just ask him one question.
Please, can you highlight one of your key findings that is relevant to hospital practice or contribution to knowledge?
So the key finding is that mostly there are policy reviews. That from time to time we have transitioned from the use of nevirapine-based combination therapy to efavirenz and then to dolutegravir. And mostly the pharmacists are not, the hospital pharmacists are not carried along in this policy change. So with this study now, it has given an insight that hospital pharmacists will have an impact in assessing if actually these transition drugs are effective or it's just because of policy that we are accepting them. So this study has actually given that sole responsibility that hospital pharmacists can actually identify the effectiveness of this regimen that we have been changing year in, year out. Thank you.
Thank you very much.
Thank you. The next presenter, ICT 03, podium 03. That is pharmacist Prince O. Okodu from Delta State Secretariat Clinic. You have 10 minutes. Hold on, let the
Group dynamics, tertiary facilities. Please, I requested for some details. I've not gotten them. Please.
Okay, your time starts now.
So, I would like to stand on all the existing protocols. My name is Van Prince Kinedo, and I'll be talking on an implementation science from a project we are currently running in Delta State. So it's about the impact of Project Stop Hepatitis B in preventing mother-to-child transmission of hepatitis B in Delta State. These are my co-contributors to this project. Just to disclose that this project got a funding from the Hepatitis B Foundation in the US. So what, just to say that about 254 million persons are living with hepatitis B, according to WHO's report alone, and Africa accounts for the most of these hepatitis B infections. When we look at Nigeria, Nigeria contributes very significantly. According to the NICE reports that was done in 2018, showed that about 20 million persons are living with hepatitis B alone in the country. And WHO also says from the reports last year, 2004, that deaths are rising from 1.1 million per year to 1.3 million as of 2022. Of course, we know that hepatitis B is a leading cause of primary liver cancer, hepatocellular carcinoma, and cancer-related mortality. But WHO has also put it that most cases, about 95% of all new transmissions are through mother-to-child transmission, and that's why we need to prevent mother-to-child transmission. Delta State, of course, from the State Ministry of Health, puts the prevalence of hepatitis B at 8%. So if we factor that with the population of 6.7 million people, we're looking at not less than 500,000 persons who are living with hepatitis B virus in Delta State. Now children, of course, have out of every 10 children born to hepatitis B positive mothers, at least 9 of them, if PMTC measures were not instituted, will become positive after all. So that's why WHO recommends that every child born should be given the birth dose within 24 hours. So this is an implementation project just to bridge this gap and then look at how we can prevent mother-to-child transmission in our health facilities. So the critical components of this project here involve early identification of pregnant positive mothers, and second, linkage to care, because that's one of the, according to WHO's reviewed guidelines for PMTCT at the moment, pregnant positive mothers should be linked to antiviral prophylaxis at least from the second trimester. So this project also looked at linking them, and also decentralization of the hepatitis B birth dose vaccine to be given within 24 hours after delivery to every newborn. So this is just the special epidemiological distribution of the hepatitis B in the globally. So our aim was to strengthen prevention of mother-to-child transmission in 5 pilot facilities in Delta State. And the specific objectives included building capacity, because preliminary assessment we conducted showed that healthcare providers' knowledge was quite poor. So we needed to build capacity and also identify positive mothers and link them to care and ensure that newborns are administered the birth dose within 24 hours. So this is just the pilot characteristics. The characteristics of the pilot facilities. There are 5 of them spread across the 3 senatorial districts. One of them a tertiary hospital, and the other 4 from secondary healthcare facilities. So our sample size, of course, Delta State currently runs an all-inclusive system where all pregnant positive women are screened within at first visit. And so all pregnant positive women registered for the ANC were enrolled into the study. But we needed to be sure. And so our sample size we calculated initially was about 2,800 plus. But because of the issues regarding missed ANC days due to public holidays, we had to recalculate, and we got 2,655 from that. So in terms of data collection, what we did was to collect data from each point from the pharmacy, from the laboratory, from the nursing departments using Kobo Collect tools, which I designed. And then we exported this data into SPSS for data analysis. We're using SPSS version 20, Ministry of Health. But strategic interventions included, first, as I said, train. We had to then screen, link it to prophylaxis, and then vaccination. So if you see the first train there, you see I was conducting training for the healthcare providers from 5. There were 30 in number, 5 each from each of the 5 facilities, included pharmacists, nurses, doctors, medical laboratory, and records persons. So this, from here, this is the ANC attendance. And if you see that the attendance was skewed towards the right, which means that to say that what we found was that most of the pregnant women prefer to start their ANC from second trimester. And so one of the reasons adduced to that was socio-cultural factors and also triaging, where each of these facilities had the number they could take per ANC. So those were some of the factors we found out. Then in terms of screening, we screened a total of 2,844 pregnant women. And what you are seeing there, we saw 53 of them who tested positive to hepatitis B. So this gives a clear picture of it. The period prevalence for hepatitis B among pregnant women was found to be 1.86%. So this has never happened before, because in data say we didn't know the prevalence for hepatitis B among pregnant women. This is going to help the ministry to plan. So, and if we did a chi-square test and also to look at the homogeneity of this distribution of positivity rates, and we found out that this was quite significantly different across. And so we are seeing as a specialist hospital with 3.39% of positivity. And so this can also help the ministry to look at what is fueling that increase. So those who were positive, we linked them to care because we provided tenofovir for them at 6 months. And we are currently following up. This project is currently on, but the data I'm sharing is from February to May. And one interesting part again is that the bed dose, WHO says bed dose should be at least 90% uptake. What we found out, in my poster, you may want to check later, last year we did a preliminary assessment and we found bed dose of 5.8%. But this project has been able to raise the bed dose uptake from 5.8% to 100% for all in-facility beds. So that's the average. And one other thing we noticed was that with this project, no child was given bed dose after 24 hours. That's the shaded what you're saying there. So all children born to each facility were given bed dose within 24 hours, which is quite impressive. And prior to the initiation of this project, the probability of any child receiving bed dose any day in these facilities ranged from between 14% to about 71%. But this has changed. All now have 100% bed dose uptake, including administration of bed dose on weekends. So this was quite impressive for us. So in conclusion, Project Stop Hep B, you agree with me that has significantly improved identification, that's early detection, linkage to care, and also to further strengthen prevention of mother-to-child transmission. And this finding will help the ministry to strengthen PMTC protocols in the state. So I just want to leave us with this picture. You know, mother-to-child transmission accounts for about at least 90% of all transmissions. And if we look at this picture, that mother-to-child transmission is like a running tap, and we need to close the tap. When we strengthen PMTC protocols, we will not only close the tap, but we will also tie it up. Thank you very much. And just to say that this project is currently under review.
Thank you. Any question for him from the audience? It's 9 minutes, 20 seconds. Okay, please. Doctor, come over, please.
Thank you so much. Wonderful presentation. Good research. Good outcomes. What I want to ask is, in your introduction, it looks like no work has been done on this particular research. Is it virgin or innovative research? That is number one. Number two, when you are reeling out your data on population sufferers of hepatitis B in Nigeria, you put it at 20 million. Descriptively, because this research is localized in this country. What is the population of females identified, males identified, maybe pregnant women identified, if there is such a research? He did your analysis. In your analysis in sample size determination, which standard method did you use? Is it Yamene of 1967? Is it Ararol, or which particular one? You mentioned tenofovir. Which of the salt formulation did you use? Ziafenamide, disproxil, or fumarate? Thank you.
Thank you very much. But I need to protect the presenter as much as possible. So I will ask that the other two questions he asked actually were for academic purpose. The first question is adequate for us, so respond to the first one. Then the other two are for academic purpose. Thank you.
So I think
Mike with you.
I think the first question you're talking about if this was a novel, right?
Yes, or innovative.
So now, this has never been done in Delta State.
Okay.
That's why it's novel.
Okay.
And the reason why this is actually an implementation science is because it's an offshoot of what we have on the poster. You may do well to find the poster, so they match. When it's just an extension of what we found. The challenges we found in Delta States last year, the issue of poor knowledge, issue of not identifying pregnant positive women, and the issue of not linking them to care, spreading hepatitis B. So that was what led us to doing this project. So it's a novel one for the ministry for Delta State, I must say.
Thank you very much. Thank you.
And it was talking, I think, about the tenofovir you talked about. So the tenofovir we use for PMTCT is tenofovir disoposite fumarate, not the alafenamide. Thank you very much.
Thank you. Thank you. The next presenter is going to be ICT podium number 4. That is pharmacist Olalekon Oluleti. Please go to the podium. Thank you. Just hold on, please. Okay, go ahead, please.
Good morning, the panelists, distinguished colleagues, ladies and gentlemen. I am Olalekon Oluleti, and I'm presenting this study on the impact of pharmacist-led innovative intervention on medication adherence and treatment outcomes among asthmatic patients attending respiratory clinic at National Hospital, Abuja. These are the co-authors to this study, and I'm the corresponding author. This is the outline of my presentation, and we'll see these keywords in the course of the presentation. According to Global Initiative for Asthma, in 2022, asthma is a heterogeneous disease defined by history of chronic inflammation of the airway and characterized by symptoms such as wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. And these incidents of attacks are more common at night or early in the morning. According to WHO, in 2003, treatment adherence is defined as the extent to which a person's behavior corresponds to the agreed recommendation from the healthcare provider. Pharmacists play several roles in the management of asthma. In addition to dispensing, they provide interventions to enhance treatment adherence in order to achieve the goals of desired therapeutic outcomes and to improve safe medication use. Statement of research problem. A World Health Organization report in 2003 said adherence to drugs for chronic diseases is only about 50%, resulting in suboptimal health outcomes and rising healthcare costs. justification for the study. The prevalence of asthma is rising despite the availability of different drugs used for its management. A significant number of asthma patients are limited with their condition, and some still experience mortality from the disease regardless of availability of drugs. And these have been attributed to poor or non-adherence to treatment and irrational use of medication. Few studies have been done about prevalence of asthma. Asani did a study on prevalence in Kano in 2005. Erabo did in Ile-Ife in 2006. Oni in Benin in 2010. Akiwu in Kano in 2016. And Kuti et al. In Ilesha in 2016. And one study was done in UCH in 2017 by Adisa et al. Now, these studies only gave us the burden of the disease and the poor outcomes of management. They were just observational studies. There was no interventional study. Hence, this study becomes necessary. The objectives of this study were to assess medication use among asthmatic patients attending respiratory clinic at National Hospital Abuja, to assess medication adherence at both pre- and post-intervention stages, and to determine level of symptoms control and evaluate the impact of pharmacist-led intervention on symptoms control among these patients. Methods. It was carried out at the Medical Outpatient Department Clinic of National Hospital Abuja among patients attending respiratory clinic at the hospital with primary diagnosis of asthma for not less than 3 months who gave written informed consent to participate in the study. This study was a questionnaire-guided prospective pre-post interventional study conducted within 16 consecutive weeks from June to September 2019. Data instrument comprised a 4-item modified adherence predictor scale adapted from Adisa et al. 2017 and a Royal College of Physicians 3 questions for quick review of asthma control, which was used to assess the level of asthma control at baseline and a month following pharmacist-led intervention. Sampling technique. A convenient sampling method was used to select all consenting adult asthmatic patients that attended MOPD at National Hospital on a continuous basis from June to September 2019. Sample size was calculated using Yamani et al. 1967 formula based on the prevalence data obtained from the Medical Records Department, and the sample size of 57 was gotten after 10% adjustment for attrition. 49 participants were recruited into the study. The eligibility criteria is as stated above. Data collection involved the use of interview-administered questionnaire, which had 6 sections. Patients were approached for participation while waiting to see physician on respiratory clinic days. The objective and the procedure of the study was clearly explained to them, and they were also assured of confidentiality of their information, and their phone numbers were recorded for follow-up. This was the intervention provided. All the participants received structured pharmacist-led asthma education at the beginning. They were counseled on adherence to both drug and non-drug treatments. And there was demonstration on how to use the various types of inhaler devices, which was where most participants or most patients missed it. And they were monitored for their post-intervention medication adherence and asthma control. Data was sorted and coded. Descriptive statistics, including frequency, percentage, mean, and standard deviation, were used to summarize data. Chi-square test was used to test association between categorical variables. Wilcoxon sign rank and McNamara test were used to compare the result of medication adherence and asthma control, pre- and post-intervention, respectively. Statistical significance was set at p less than 0.05. This study was duly approved by National Hospital Abuja Ethics Committee, and that is the code of the ethical clearance displayed there. Results. The results obtained showed that most of the participants were females, aged 30 to 44 years, married, and were civil servants. Most of them were diagnosed within 1 to 5 years of the study in a general hospital. And the result also showed that cough was the most symptoms experienced before diagnosis. And majority of the participants reported family history of asthma, which was evenly spread. They also reported that there was allergen that triggered the symptoms, and dust was the most implicated allergen, followed by cold air. These are more common in harmattan season, so that is when the asthma patients should take greater precaution. Majority of them admitted to experience attacks more during the cold weather. And salbutamol inhaler was the most used drug among the participants, followed by seretide inhaler. That's a combination of salmeterol and fluticasone, and then other drugs as listed. Now, assessment of medication adherence among the patients attending the clinic showed that 57.1% admitted that they used to forget to take their medicine before the intervention. But after pharmacist-led intervention, this number dropped to 23.8%. 40.8% admitted that they are usually not being careful about taking their drugs before intervention. This reduced to 21.4% after the intervention led by the pharmacist. 72.9% admitted that they sometimes stopped taking their drugs when they felt better. This reduced to 14.3% post-intervention. 40.8% stopped taking their medication if it made them feel worse. This reduced to 23.8% post-intervention. When scored on the adherence scoring table, it showed that pre-intervention, only 4.3% had good adherence. But after the pharmacist-led intervention, the adherence increased significantly to 76.2%, as shown by Wilcoxon signed rank. Opinions on factors responsible for poor medication adherence among the participants showed that forgetfulness, daily and continuous use of medication, complex dosage regimen, and use of herbal remedies were significant reasons why patients don't use their drugs. Also, on treatment outcomes, on asthma control, the number of those that experience reduction in control, that had their asthma control, increased significantly after pharmacist-led intervention. Summary of research findings is as stated earlier, there was improved adherence after pharmacist-led intervention, and there was also significantly improved treatment outcome after pharmacist intervention. So we could conclude that following pharmacist-led intervention, there was improved adherence and treatment outcome. This is the ethical clearance. These are some of the tools used, and these are some of my references. Thank you very much for your attention.
Thank you. One question from the audience. Please, anybody? Okay. It's only one question we are taking, sir.
If you watch, this work is well done. But what I'm asking from the assessors, all this work, this one is supposed to be published. This work, I'm looking at some things from introduction. Did it pass through relativity index? Is there any plagiarism checker on it? Yes, we are going more scientific. So we have to be over standard. Is there any plagiarism checker? Maybe using Quibot, Grammarly, or checker index? That is what I'm asking.
That one is noted for academic concern, but is there any other question relating to the intervention with respect to the presentation? We are actually noting what he has said because indeed what we are doing should go to the next level so that our presentations are up to the level of international best practices. So we have noted, and as a committee we are noting that in the pre-conference assessments, and we will make it as benchmark for such interventions. Okay, hold on.
Thank you for a wonderful presentation. I want to know, how did you measure adherence? Because this work is all about patient adherence. How were you able to measure adherence?
Thank you very much, sir. It was stated on the slides there is a four-question modified adherence predictor scale adapted from Adisa et al. 2017. In 2017, there was a study done in University College Hospital Ibadan by Professor Adisa, a professor of clinical pharmacy. So it was a questionnaire he used, which he adapted from Professor Donald Moriski. That was the questionnaire that was adapted to assess adherence in this study.
Thank you very much. Before the next presenter, I've been asked to announce Chairman and Secretary of Kwara State. If they are here, please, their attention is needed on the table. No question. Chairman from Kwara and the Secretary, Kwara State branch, please. The next presenter, because we are running out of time, is ICT podium number 5. That's what we are presenting. That's Dr. Amaka Ezioku from Nnamdi Azikiwe University Teaching Hospital in Nnewi. You have the floor. Okay, you can start, please.
The panelists, my colleagues, good afternoon to you all. I am Dr. Amaka Ezioku from Nnamdi Azikiwe University.
Hold on. Is this the right presentation? Look at it.
No.
No, that's not a podium. That's not the one. 05, not 06. 05. Just hold on. We have not started timing. Okay, it's there. Go to the first slide, please. Okay, your time starts now.
Yeah, my topic is on pharmacist intervention for drug therapy problems in a Nigerian tertiary hospital, a pilot test of acceptability by other healthcare professionals. Introduction. Drug therapy problem are widespread and negatively impact on patient outcomes, healthcare costs, and even public health trust. Clinical pharmacists play vital roles in identifying and resolving drug therapy problems, and then prescribers have shown strong acceptance of these interventions. Strengthening pharmaceutical care roles are essential to improving patient care and overall healthcare system performance. Statement of the problem. Drug therapy problem is a common occurrence, like I've said, and has hindered the desired therapeutic outcomes of these patients, thereby demanding more committed pharmaceutical care among these patients. And then the approval of consultant pharmacists has expanded this role we're expecting. However, inclusion of pharmacists into the multidisciplinary team still remains a contention in many Nigerian hospitals. Objectives is to assess the drug therapy problem intervention acceptability and perception of pharmacist relevance among healthcare professionals in Nnamdi Azikiwe University Teaching Hospital, Nnewi. Ethical consideration. Before we went into the study, we got approval from the Youth Ethics Committee, and we also got authorization to carry out the study in the pharmacy units from the HOD pharmacy. We also observe other ethical issues, like we try to anonymize all data we collected from both our patients and the healthcare professionals. Setting, the study was done in Nnamdi Azikiwe University Teaching Hospital in Nnewi. We included both our inpatient and outpatient units. And overall, we studied 6 pharmacy units, 3 consulting clinics, and 3 wards. Inclusion and exclusion criteria. In the DTP identification and intervention study, we included all the prescriptions we received during the day work and removed the ones we received during weekend and call duties. Then among the doctors and nurses study, we included all the doctors and nurses that work in the study units, and also those that have stayed for 3 years and above. The design was a cross-sectional study, and the sampling technique was purposive. We used purposive sampling to select the units we studied, and we used consecutive sampling technique to select the subjects we recruited in the study. The study period was for the DTP identification and intervention. It took us from November 2024 to April 2025. And then for the healthcare professional survey, we did it between May and June 2025. Sample size determination. In the DTP intervention study, we used total population sampling of all the prescriptions we received during the day. Then for the healthcare professional survey, we calculated our sample size using a method that incorporates pilot variable into it. At the end of the day, we arrived at 5 healthcare professionals, which we surveyed. However, considering attrition of 20%, we made our population to be up to 42 healthcare professionals, which we rationed into the ratio of 1:1.6 between the nurses and the doctors, respectively. The data collection method, before we went into the data collection, we first of all we had an in-house training of someone we designated as a DTP focal pharmacist, whom we now posted to these various units of our study, and then he anchored the DTP interventions and then documented activities. Instrument for data collection, of course, we use prescriptions, we use physical contact during interventions, and we use questionnaire to survey the healthcare professionals. We also consulted some relevant documents, like we used the Pharmaceutical Network Europe classification system for DTP classification version 9.1, 2020, in classifying our DTPs. And then we consulted BS criteria 2023 for classifying inappropriate drugs used in the elderly. We now did the data analysis and made a comparison using chi-square at p-value of less than or equal to 0.05. Our results is in 2 sections, one for the DTP intervention and the other one for the healthcare professional survey. In the DTP intervention study, we had 68 prescriptions that had DTPs at the average of 11.3 DTP per unit per month. And 76 DTPs were identified from these 68 prescriptions, and at the approximate average of 1.1 DTP per prescription. Females constituted 76.5% of the DTP patients, and then drug therapy problem was highest in accident and emergency, 27.9%, followed by GOPD and maternal and child health emergency, which accounted for 19.1% respectively. Antibiotics ranked first among the culprit drug classes, accounting for 32.9%, and then followed by NSAID, which accounted for 16.5%. Then on the professional survey, 42 healthcare professionals went into this survey. 61.9% of them were doctors, and 38.1% were nurses. Majority of them were within their middle age career stage, and then 50% of them have passed 10 years experience. Table 3 shows the DTP, the attitude of these healthcare professionals to our DTP interventions, and then how they perceive the relevance of pharmacists in our youth. You can see that all the healthcare professionals, 100%, actually believe that pharmacists have a vital role to play in patient care. And not only that, they also believe that this role they play actually contribute a lot in the outcome of these patients. And 97.6% support collaboration with pharmacists, 78.6% support word round with pharmacists, 3.3% support collaboration with consultant pharmacists, and as much as 90.5% believe in the contribution of the consultant pharmacists. So this shows this table shows the DTPs, the resolution we made. Sorry. This shows the DTPs we identified. The major DTP identified was, sorry. What's happening? So this shows practice of DTP, acceptance of DTP. 64.3% of the healthcare professionals have received DTP from pharmacists, and 14.3% of them have frequently received it, even though more than 80% have never received. And 92.9% show positive reception. 97.6% are comfortable with the intervention. They are ready to re-prescribe if it comes to that. And 100% of them are ready to implement recommendations made by the pharmacists. This is attitude to DTP intervention and perceived relevance of pharmacists. What is happening? Sorry, in the discussion, the pilot study actually reviews substantive value placed on pharmacists by healthcare professionals in NIUT. And the occurrence of DTP in 1.1 DTP per patient shows that it is very common in agreement with other studies. Dosing error is the most prominent as in other studies. This is the barrier. In conclusion, this study acknowledged NIUT pharmacists' vital role, emphasizing on approaches to enhance interprofessional collaboration and integrating pharmacists into the multidisciplinary team, recommending strong emphasis on role clarification, improved communication pathway, and strengthening professional engagements. Thank you.
Thank you very much. One question. You want to? Okay. Okay. There, please. Thank you.
Thank you, sir. Well done, the distinguished presenter. Mine is just a short question. During the course of your presentation, you made mention that 31 doctors were used in the research. You said 31 doctors, if I got you right. Now, what I want to make clear, you know, when you say doctor, being a research, you should have used the right diction in that particular, because we have MD graduates who are also doctors. So what is the right and appropriate word you're supposed to use instead of doctors? Because doctor is a qualification and which everybody is entitled to bear. Thank you.
Any other question? I think that's more of a comment. Okay. You.
Thank you, presenter. This is a very relevant one, considering the evolution of our practice in Nigeria now. My question is that you highlighted the most frequent DTP. Please, what is the list out of all the DPTs you considered? Which one is the least? I understand you said dosage was the most. Which one is the least?
Thank you. Please respond to him. Go ahead. You have the mic. Use your mic, please. Is it on? Is your mic on? Let me borrow you mine, just to save time.
Inappropriate dosage form and then contraindication. The two of them, 4%. Where they did.
Thank you very much. The last presenter for our session, as we are running out of time, is podium number 6, ICT. Yes, the last one. Okay, that will be 5. Podium number 5. Pharmacist Eze Ijoma. Thank you. Okay, your time starts now.
Good afternoon, distinguished panel of judges, fellow delegates, ladies and gentlemen. Please permit me to stand on the established protocol. I'm Eze Ijoma of the Department of Pharmacy, University of Benin Teaching Hospital, here to make a presentation with the title, Drug Therapy Problems and Outcomes of Pharmacist Interventions in Prescriptions for Outpatients with Type 2 Diabetes mellitus at a tertiary hospital in Benin City. Here is my outline. Now, drug therapy problem is of a major challenge to healthcare providers. It is an undesirable element experienced by a patient in the course of taking his or her medication that could interfere with the desired outcome of that therapy. This thing is it's malfunctioning. Okay. Various studies conducted within and outside the country, shows a prevalence of 42.3% to 100% prevalence of drug therapy problems in patients with type 2 diabetes. Now, intervention can be defined as an action carried out by the pharmacist that can necessitate a change in the patient's therapeutic regimen. It's not working. Now, in Nigeria, there's a depth of studies on pharmacist intervention on drug therapy problem of major clinical significance. And of course, we know that patients with type 2 diabetes receive multiple medications, exposing them, to drug therapy problems. And this is further enhanced by the presence of drug therapy problem. And of course, if left unresolved, could definitely result to mortality. I don't know why this. Therefore, this study was aimed at assessing the prevalence of drug therapy problems in prescriptions of patients with type 2 diabetes mellitus while evaluating the recommendations made to the physician and, of course, identifying the outcomes. Here also are the specific objectives. Now, the methodology for this study was a prospective, descriptive, cross-sectional, and interventional study carried out at the outpatient department of the University of Benin Teaching Hospital, spanning a period of 2 months. And of course, the inclusion criteria involved patients that was not their first visit to the pharmacy. Those that have been previously given medication and has been counseled on their drugs for drug therapy for type 2 diabetes mellitus. Therefore, exclusion meant those that were coming for their first time were not recruited for this study. And of course, the selection method was through systematic sampling method. Now, for this study, it was a prospective time-bound study, therefore making us to recruit a total of 78 patients. Now, this was a data tool that was used for the study, comprising of the demographic characteristics, now the drug therapy problem identified, recommendation that was made, and of course the outcome of the intervention made. Suffice to mention that, of course, all the information given here was anonymized. Now, the Sipol et al. Classification was used in identifying the drug therapy problem and identifying the class and causes of the drug therapy problem. And of course, we know that with that classification, there are about 8 classes of drug therapy problem. Intervention was, of course, made by writing a recommendation in person or via a consult to the physician, who in turn obtained. And of course, ethical approval was gotten from the Health Research and Ethics Committee of the institution. Now, going to our results, We can see from these studies that a majority of the patients were female, as identified by the 67.9% of female that were seen from the study. This actually does not align with studies I know carried by Sharif et al., Agor et al., wherein we saw majority of the patients falling into the male domain. And of course, it's necessary to note here that the comorbidity most experienced in this study was hypertension. Now, it's noteworthy to mention here that there was a high incidence of polypharmacy, as can be seen from the account given, 91.2% in this study. Herein, we can see the prevalence of drug therapy problem. And as we can see from this study, interestingly, up to 82% of these patients encounter drug therapy problem. And it's necessary to note here that this is also aligning with studies carried out by Sharif et al., Agor et al., Ogbonna et al., where there was high prevalence of drug therapy problems. Now, from here, we can see that the potential drug-drug interaction was most accountable, giving a total of 68.54% in prevalence. And the least, of course, we can see was unnecessary drug therapy and actual adverse drug reaction. Here also we can see that pharmacodynamic interaction of potential drug-drug interaction accounted most for the causes of drug therapy problem, as can be seen with the alarming 65.6% contributed by that cause. Now here we see the stratification of the level of clinical significance of these drug therapy problems. And as can be seen from this study, 51% were of moderate clinical significance, and this also aligns with various studies as carried out by Sharif et al., Agor et al., where, of course, most of the DTPs identified were of moderate clinical significance. Also noteworthy is the fact that 17% were of major clinical significance, and it's upon these ones that we actually made our recommendations to the physicians for appropriate intervention and change. I'm having trouble with this. Very well. For the recommendations made and the outcome, as can be seen from this slide, about 24 recommendations were made to the physicians, that is of those of major clinical significance. And it's interesting to note that 12, that is about 50% of these were contributed by drugs that exposes the patient to potential drug-drug interaction, spanning this pair of drugs. Next to this was need for additional therapy. As we can see here, 7 were contributed by that. And it's noteworthy to mention that of these, 6 were attributed to the need for addition of vitamin B12 to their drug components. And as we all know, these patients are on chronic use of metformin, which actually predisposes them to depletion in vitamin B12, requiring the need for us to add this component. And it's interesting to say that the physicians agreed to that in the sense that they added the drug to their drug component. Next to this, is having it's not, the pointer is having a problem. ICT, the pointer is having a problem. Okay. Recommendations to be made. And of course, if we know the co-administration of this drug exposes these patients to angioedema and of course eventually to pulmonary depression, requiring the need to change the drug from an ACEI to an AROB or possibly change the pregabalin to gabapentin. And of course, this was accepted. Now, for the outcome of the recommendations made, as can be seen from the previous slide, this thing is, as can be seen from the previous slides, change of therapy was most of the recommendations made. And of the 24 recommendations made to the physician, of the 24 made 20. Now, in conclusion,
Time up.
the study revealed high prevalence.
Time
high
up. It's
acceptance
okay.
rate of
So,
pharmacist intervention.
please, one question for her. Pharmacist Tijani.
All right, thank you very much. The question may not be for only you, and it goes like this. Have you done a kind of step down to the management of the facility where this research were carried out, because it shows how impactful and will improve the relevance of pharmacists? Thank you.
Yes.
Okay, go ahead, please.
Like as from the studies or from the outcome of the study, we could see that there was high acceptance rates of the physicians to this. And this attests to the fact that there's a high mutual understanding, mutual respect between the pharmacists and the physicians. They accept the fact that this is a requirement for us as pharmacists to carry out. So there's a high acceptance of the physicians to this. Likewise, to mention that it's also attributed to the communication we have with these physicians. We try as much as possible that when we are communicating, we are precise, introducing ourselves, giving a background of the situation, presenting the situation, making appropriate assessments, and of course, giving necessary recommendations so that within that recommendation, they are able to bring out what they actually want, and of course, the necessary intervention is made. So, to a large extent, the institution is quite aware of what we're doing.
Okay, madam, you had the prospective cross-sectional intervention study, and you used systematic sampling.
Yes.
What was your sampling framework?
That is one in every 3 patients that comes into the pharmacy. It was a systematic sampling method. Therefore, in every three that comes in, we pick a patient.
Thank you very much. Thank you. I will hand over to the chairman to invite the others for our group. We'll engage information. Okay, sir. With the permission of the chair, information.
The panel of judges, I want to point something out. I watched the presentation, that we are all beautiful. But I discovered that there are 3 methods used. Some were using Harvard, some were using APA, some use Vancouver. Which one is accepted method for AHAPEN here? Which one are we using? Is it Vancouver or is it APA, please?
Thank you very much. As I said earlier, that was taken care in the pre-conference assessment. So we actually used the Harvard method for assessment and corrected them. But, you know, the criteria for assessment here, that is not factored because other aspects of parameters for assessment were the ones for the presentation. But indeed, we let them know this is the acceptable format for referencing we are going to use. Thank you. Noted. Please, we will engage more, and it's because of time. It's a matter of time indeed.
As an association, even when many options are correct, as an association, we can say this is what we want. Because tomorrow we are becoming our guests so that it will be understood. So it will come from this table to us so that we go home with it. That's why we are here.
Thank you. Chairman, over to you.
Yeah, thank you so much. I think I want to agree with the suggestion by Dr. Wanfuro that we should have, for the sake of uniformity of practice, which is what we mentioned at the beginning of this session. So for the sake of that, I think it's important that we stick to one particular method, and Harvard method is so I think believe it's okay. So your committee should take note of that for future purpose. Is that okay, Dr. Daraka? Okay, thank you so much. I want to call on an editor-in-chief to very, very quickly make a presentation, please. We are really out of time. group photograph first? Okay, fine. So we want to request for all the presenters and the poster presenter. Okay, all of you should please come forward for the group photograph. Thank you. Can you please come forward for the group photograph?
Back through the years.
Dynamics committee.
Back to the seasons of.
Please, can you come forward for the group photograph? I think we used chair the last time. Okay. Yeah, let them arrange.
And how my mama put the rags to use.
Congratulations to all of you.
There were rags of many colors, but every piece was small, and I didn't have a coat.
Poster presenters,
It
can you
was
please come
away
for
down
the
in
group
the
photograph?
fall.
Thank you.
Mama sewed the rags together, so in every piece with
Nimel.
love she made my coat of many
Meg,
colors.
get ready for your
I
presentation.
was so proud of. As she sewed, she told a story from the Bible she had read about a coat of many colors Joseph wore, and then she said, perhaps this coat will bring you good luck and happiness. And I just couldn't wait to wear it, and Mama blessed it with a kiss. My coat of many colors that my mama made for me, made only from rags, but I wore it so proudly. Although we had no money, I was rich as I could be, in my coat of many colors my mama made for me. So with patches on my breeches and holes in both my shoes, in my coat of many colors, I
So much.
hurried off to school.
At this
just to
point, we
find
want to
the
take
others.
the presentation by our editor-in-chief. Gabriel, how many minutes does she have? How many minutes does she have? 5 minutes. Okay, they said 5 minutes. Please go ahead. Thank you. 5 minutes.
AGM starts in the next 20 minutes, please. So please get ready. Meg, Nimel, are you ready? Where's the third company? Sam. Sam, are you ready? Sam. Sam Pharmaceuticals, are you ready? IT, please. Dr. Ngozi, you have 5 minutes, please. Your time starts now.
The spirit of life calling.
Dr. Ngozi, your time has started. AGM is in the next 20 minutes, please.
Good afternoon, my colleagues. I am Dr. Ngozi Kadora today, the editor-in-chief of AHAPEN. My primary base of work is in compounding pharmacy department and quality control, UNTH Enugu. And I'm presenting on compounding practices of various dosage forms in the development of pharmacy UNTH. These are my outlines, the introduction, the objectives of good compounding practices, quality assurance, the SOP of various simple production, and conclusion.
what is introduction? It shows that from studies done in US that 3% of every prescription coming from doctors are compounded. 3% only. However, in Canada, you find that 23% of prescription for pediatrics are being compounded. In UK, we have very few compounding practices being carried out there. However, in South Africa, we find out that only dermatology cases, preparation like semi-solid creams, ointments are prepared there, are frequently prepared. Now, what is the definition of compounding? We have heard compounding so many times from people who have presented, but this afternoon, I just want to bring out very important points, a take-home point, which all of us will stay here to deliberate. Compounding pharmacy is any pharmacy that provides medication that are not commercially available and prepare them on site to meet patients' needs. Then what are the benefits of compounding? One of them is when we want to change the strength, dosage form, that is not commercially available, or when we want to change the taste of preparation for children so that it will be acceptable for them, and then sometimes when we have shortage of drugs. Now, we don't have 5-fluorouracil cream, we don't have promethazine cream, and so many other creams, and we have them in injections. So by compounding, we convert the injection of 5-fluorouracil to cream, injection to cream, and then promethazine injection to cream. Also in US, they find out that this compounding medication for those who want to lose weight, that's the fund, is ongoing, and many people are going for it. Hello? By this method, compounding pharmacies can get access to the chemical compounds directly from drug manufacturer and mix the medication to see the patient's needs. We have risk in compounding. Some people opt out because there are many cases of compounding that have caused loss of life of patients. One of the ways that we have this risk is when we have wrong calculation that leads to overdosage and toxic diseases that leads to death. Next one again, when we don't clean the table surface, there are contamination that leads to the products having microorganisms that causes people to have infection and leads to death too. And then when we have poor sorting of raw materials, sometimes in the past we have a case of people producing propylene syrup with propylene glycol. So the propylene glycol has been specified and causes the loss of death of children. Now, compounding practices in UNTH. Number one of them is that we prepare prescriptions, especially for children or dermatology, based on doctor's prescription. Sometimes we have patients that have allergy, and we prepare a solid dosage form without the allergen like lactose. Sometimes also we convert the tablets to syrup, tablets to cream, injections to cream to suit the patient's needs. At our pharmacy, we are careful to follow all regulations surrounding the mixture of pharmaceutical ingredients. We do our best, not only to supply to pharmacies in UNTH, we also get prescription from all the doctors all over Nigeria to prepare for them.
Chief, my presentation is...
What are the things that we prepare? We prepare lozenges. Lozenges is where you prepare a solid dosage form that you put under the tongue and you soak for 3 minutes and it's absorbed. Sometimes also we prepare suppositories like paracetamol suppository, hydrocortisone suppository, and diclofenac suppository.
Time up.
We check
Dr.
also,
Gosti.
do we have this compounding being produced outside USA? Yes, it's being as requested for. Next again, do we do the training? Yes, we do the training. And do we carry the quality control to ensure they are produced? Yes, we have quality control pharmacies that carry out the product analysis. And finally, we also said that in making sure that the products are being done very well, quality assurance are being put in place by using the correct personnel, correct equipment, and correct premises to avoid contamination.
Time up, Dr. Ngozi.
Our UNTH is a place where we produce compounding drugs that really help to prepare products that suit patients' needs. And going further, we are saying that we don't wait until the doctors write out the prescription. However, what you can do, you can request for it. All right? And in the West, finally, in the words of core pharmacy, Canada, they said compounding pharmacies is now pharmacy, whereby you prepare things that suit patients' needs. And in that note, the American Association are holding compounding training in Lagos in October 9th. And there you have access to a formula, you will have access to equipment, you have access to people that can help you set compounding in your unit. Thank you so much.
Merck Pharmaceuticals. Merck Pharmaceuticals.
Thank you so much, Honorable National Secretary AHAP. I sincerely want to appreciate, hello House, I want to appreciate AHAP, NEC and Council for the privilege of being appointed to oversee the group dynamics in this 26th Annual National Conference. We are very grateful for the opportunity. And sincerely, I want to appreciate also the various the committee members for the job they did, and the presenters as well for for painstaking and very thorough presentations. In the course of the presentation, we appreciated some of our members. We called on I know we recognize the PS, our own PS, Dr. Didier, who was not here at the beginning, but he's here right now. Dr. Didier, we appreciate you so much. Yes, he hosted us on the opening ceremony day, and yes, up to now, I'm still picking my teeth from the meats that you served us at that function. And we're looking forward to another one tomorrow morning, if it's possible. Thank you so much. May God replenish your purse for your sacrifice. I want to challenge all of us by way of closing now that we should try and engage in research. Pharmacists have access to huge information that we can harness and publish. Okay, in the academia, the slogan there is publish or perish. But the truth is that as hospital pharmacists, administrative pharmacists, we have access to data. I want to challenge us to try and publish as much as we can. But from being a core requirement of Federal Ministry of Health, like I said earlier, when you publish, you contribute to the body of knowledge, and patients can also benefit. Patient care will improve when you do that. And our pharmacy practice is a dynamic practice, okay? At every stage, you are required to publish. The May and Baker Award of PSN is research-focused, research-based. And the Pfizer Excellence Award, too, is equally research-based. And then for other groups like Academy of Pharmacy, they insist on research, okay, before you can be admitted. I personally have benefited from research. Today, by the grace of God, when I left the hospital services, I'm the academia now, and I was employed based on the number of research articles I have published. So I want to leave you with this word that please try and engage in research in your little corner for the benefit of the patient. Thank you. God bless you all. Thank you.
Meg, your time starts now.
Thank you very much. Good afternoon, men of honor. Permit me to stand on the existing protocol. I am back again for our second presentation. My name is Audu Ilya, and I work with MEC. I prepared a 15 minutes presentation, but I'll do my best to ensure I finish before 15 minutes. If you look at the screen, you would see the mathematics that says 1 + 1 = 3. We'll be talking about hypertension and how does 1 + 1 = 3. We define the combination that I'm going to present this afternoon as a fixed dose combination that adds up for your hypertensive patients. So we'll be looking at a fixed dose combination of amlodipine and bisoprolol in a tablet called Concor AM. Now, for most of you that know the story of Merck, from 2017, we launched bisoprolol as a molecule. And through our work, we've made bisoprolol quite popular in the management of cardiovascular disease, heart failure, myocardial infarction, hypertension. So this afternoon, I'll be talking to us about the rationale behind this formulation that leads to this equation called 1 + 1 = 3. This is the overview of my presentation. Now, there are multiple systems that are involved in blood pressure regulation, of which we can see the autonomic nervous system, and then the renin-angiotensin-aldosterone system, and the vascular contractility. At the moment, this combination cuts across these three systems, and we'll be seeing how it does this. Averagely, 75% of hypertensive patients would need more than monotherapy in order to achieve blood pressure control. So it is important to manage patients with combination treatment, especially to tackle these different aspects that needs regulation so as to normalize patients' blood pressure. So for the purpose of this presentation, picture a middle-aged patient that is between 40 to 60 years of age, having a grade 2 blood pressure range of a systolic of 160 to 179 millimeter mercury, and a diastolic blood pressure range of 100 to 109 millimeter mercury. And say that patient is sympathetically overdriven, in the sense that the heart rate of the patient is greater than 80 beats per minute, and the patient is giving you symptoms that are mimicking the flight response, the response from the autonomic nervous system, saying, I find it difficult to sleep at night, sometimes I feel anxious, sometimes I have localized sweating and all that. Now, this kind of patient is the patient that I'll be referring to in the course of my presentation. So what are guidelines saying as regards the combination of antihypertensives? They've identified 5 major classes that you can use as in combination for your patient's blood pressure management. But if you look at the second bullet points there, you would see that they said beta blockers should be used in specific indications, particularly angina pectoris, post-myocardial infarction, heart failure, and then heart rate control. Now, in terms of heart rate control, when we're talking about intervention in heart rate, a lot of clinicians will think you're talking about frank tachycardia. So why are they not saying tachycardia in this case? Rather, they are saying heart rate control. If you look at the findings from the Framingham Heart Study, you heart rate at beats per minute on the vertical axis versus the incidence in terms of all-cause mortality from cardiovascular disease and then chronic heart disease. It was seen that for every increase in 10 beats of the heart rate, these factors also increase. The incidence of these primary endpoints also increase. So what this is now saying is that as you're lowering your patient's blood pressure, you should also pay attention to the patient's heart rate, because resting heart rate values are independent predictor of cardiovascular events in hypertensive patients. So that is why the European Society of Cardiology and the European Society of Hypertension had included among factors influencing cardiovascular risk in hypertensive patients a resting heart rate value of greater than 80 beats per minute. So heart rate is an important target in blood pressure control. Now, guidelines are talking about fixed dose combination. If you use 2 or more molecules, they are also saying that this should come as a single tablet so as to enhance adherence for your patient. For us, we have a combination of a beta blocker and a calcium channel blocker called Concor AM. That's what we're advocating for this patient. So why should you choose bisoprolol for your hypertensive patient? Among beta blockers, bisoprolol has the highest cardioselectivity for beta-1 receptor than it does for beta-2 receptor. It is 19.6-fold more selective for beta-1 than beta-2. So what this means is that the beneficial effect from the stimulation of beta-2 receptors for your hypertensive patient won't be affected by Concor. So your patient will still benefit from having the impact of adrenaline and noradrenaline on beta 2 receptors. It is also a beta blocker that is administered once daily, and it gives 24 hours coverage for your hypertensive patient, and its pharmacokinetic parameters are so favorable that renal impaired patients, hepatic impaired patients can also take it. So why should you also choose amlodipine for such a hypertensive patient? Beyond blood pressure lowering effect, amlodipine is one of the dihydropyridine calcium channel blocker that has also shown impact in endpoint studies in terms of lowering risk of stroke, lowering coronary artery disease for hypertensive patients, and it's also dosed once daily in blood pressure management. You could see several studies, the ASCOT study, the VALUE trial, the CAMELOT study, that have actually shown solid endpoints aside just lowering blood pressure in terms of the use of amlodipine. So if you use Concord AM, you're conferring the benefit of both bisoprolol and amlodipine for your hypertensive patient. So how does 1 + 1 add up to 3? If we can just look at the equation once again. Amlodipine as one variable, bisoprolol as the other variable. Amlodipine will cause significant vasodilatation for your patient, while bisoprolol will act on the beta 1 receptors on the heart to lower the heart rate for your patient, and then also act on the beta 1 receptors in the kidney to inhibit the renin-angiotensin-aldosterone system. Interestingly, the rate-limiting step for the activation of the RAS system is the release of renin. So, and the release of renin, one of the pathways is the stimulation of beta 1 receptors in the kidney. If bisoprolol blocks the beta 1 receptors in the kidney for a sympathetically driven patient, it will prevent the renin release, which is the rate-limiting step for the activation of the RAS system. So that's how 1 + 1 adds up to 3 for your hypertensive patient. So if you have such a grade 2 hypertensive patient that treatment is initiated with Concord AM, the blue line dotted with gray spots, versus when amlodipine is initiated as a single monotherapy, you can see that there's a rapid blood pressure reduction that is seen with Concord AM, evident within the first 2 weeks of administration, about 22 millimeter mercury. So your patient is coming from 160 to about 140, and this blood pressure reduction continues even to the 4th week until your patient's blood pressure is normalized. If you have a patient that is already on amlodipine and bisoprolol as free combination, and the patient is not getting their blood pressure control, these researchers actually looked at, instead of adding a third agent, could we try a fixed dose combination for this patient to see whether this will enhance blood pressure control? It was seen that patients that were transferred from free combination of 2 separate tablets of bisoprolol and amlodipine uncontrolled to Concord AM had a further 16.4 millimeter mercury drop in systolic blood pressure and 8.8 millimeter mercury drop in diastolic blood pressure. So beyond just a fixed dose combination, this works as a single pill. Now we'll be wondering as pharmacists what's behind this magic. The researchers went further to explain, because they looked at the plasma concentration of amlodipine and bisoprolol from Concord AM vis-a-vis the plasma concentration of amlodipine and bisoprolol from these 2 separate innovator tablets. It was seen that the bioavailability that was gotten for Concord AM for both bisoprolol and amlodipine were higher. You could see the spots that are colored more, versus when free combinations were given as 2 separate tablets. So your patient gets more drug delivered to the site of action from Concord AM as a fixed dose combination versus when 2 separate tablets are given. There are several ways to explain this analogy, just in case if it's not clearly understood. Now, with Concord AM, in terms of safety, several studies have actually shown that your patient would get good adherence, better blood pressure control when on Concord AM as against when on free combination. You could see in terms of normalization of blood pressure, the results for these 4 different studies favors Concor AM as a fixed dose combination as against the free combination. In terms of side effects, Concor AM as a fixed dose combination is well tolerated by over 10,531 patients that were enrolled in this study. And so this means that your patient will comply with the treatment. And then there's also a balanced hemodynamic effect from these 2 agents, because the significant vasodilatation you get from amlodipine can lead to an increase in your patient's resting heart rate. But with bisoprolol in the system, it normalizes that heart rate for the patient. So you have 2 molecules with good synergy for a hypertensive patient. So in conclusion, you have a fixed dose combination that can show a rapid blood pressure control evident within 2 weeks for your hypertensive patient. It is also well tolerated because it has favorable safety profile, increased adherence for your hypertensive patient, especially your middle-aged patients that are sympathetically driven, having a grade 2 blood pressure range and a resting heart rate value of greater than 80 beats per minute. We have 2 strengths of Concor AM in our market, 5.5, Concor AM 5.5 and Concor AM 5.10. So you have 5 milligrams of bisoprolol combined with either 5 milligrams of amlodipine or 10 milligrams of amlodipine. So thank you very much for your time and your attention. You could make this fixed dose combination available in your centers to help enhance your patients' adherence, to also give them this significant blood pressure control that is associated with Concor AM. Thank you very much. 1 + 1 = 3.
Thank you very much for that presentation. Is the medical representatives of NIMEL around? NIMEL, are you there? Okay, please. Your time starts now, even before you get here.
And a voice with the fear of a child.
Chairman.
Answer.
Good afternoon, everybody. My name is Onyeka Ajibo from NIMEL. I want to thank all of you here. I want to thank the ESCO of AHAPEN and other guests here. We are from NIMEL, and I'm here to present to you the use of clothalidone as a monotherapy and a combination therapy in the management of hypertension. NIMEL Pharmaceutical Limited is an indigenous company which most of us here are aware. We manufacture all our brands, about over 50 products in Nigeria. We are innovative and research-oriented. We are known for production of high-quality and affordable generic products. We are incorporated in August 2001. Our head office at plot 35 AHAPEN Industrial Layout, Enugu. We are licensed by PCN and NAFDAC and have about 200 of staff. Introduction. Hypertension still remains a public problem. It is estimated to affect over 1 billion people worldwide. Sub-Saharan Africa contributes to about 2/3 global burden of hypertension. In 2014, hypertension prevalence in Nigeria was estimated to be 28.9 by the WHO. And research has also demonstrated that although possible, it is usually difficult to achieve BP control with monotherapy. And because of that, 25% of hypertensive patients needs monotherapy. And 50% of the hypertensive patients will need dual therapy. And about another 25% will need triple or more combinations. By JNC 8, it's recommended that 2 drugs are used for blacks as first-line treatment of hypertension. One is thiazide and thiazide-like diuretic, such as hydrochlorothiazide, clothalidone, and indapamide. Second is calcium channel blockers, like nifedipine and amlodipine. But for cases of chronic disease failure, ARB and ACI should be used. On this presentation of clothalidone as a monotherapy and a dual combination, we are going to look into the pharmacokinetic, the mechanism of action, the advantage of clothalidone over thiazide diuretics suitable for indication and side effects. It has a long half-life, 20 to 30 hours, and therefore a prolonged diuretic action, which results in conducive direct effect despite a skip dose. What it means, cypress is also eliminated from the body mostly by the kidney as a chain drug. In person with diminished kidney function, the clearance of clothalidone is reduced, and the elimination half-life is increased. When you look at this diagram now, you also discover comparison of hydrochlorothiazide and clothalidone. Looking at clothalidone, 2.6 hours on the onset of action. On the peak effect is 1.5 to 6 hours compared to hydrochlorothiazide 4 to 6 hours. In excision pathway, urine as a exchange drug in hydrochlorothiazide, but in clothalidone is also noticeable. Clothalidone inhibits the reabsorption of sodium and chloride in the distal convoluted tubules of the kidney by acting on the sodium ion pump. And also, the reduction of sodium resorption subsequently reduces extracellular fluid and plasma volume through an osmotic and sodium-driven diuresis. In addition, clothalidone antihypertensive effect, there are strong evidence from meta-analysis that it reduces the risk of stroke, myocardial infarction, heart failure, in hypertension, and the mechanism of this has been traced to this role. It plays in platelet aggregation. It is more potent than the hydrochlorothiazide, 1.5 to 2 times more potent, having longer duration of action, up to 20 to 30 hours. Clothalidone also has shown stronger superior clinical evidence in control of BP by JNC8 reports. And the American Cardiac Society recommended clothalidone as the preferred diuretic for first-line treatment. So in this, we have some side effects of clothalidone, which also we have in other drugs. But on this, the symptoms are usually mild, rare, and may go away within a few days. Also, one of the side effects of clothalidone is also hypotension. That's why our patients should be monitored closely while using also cypress. So on this, what we did was, as I told you, that clothalidone can be used as a mono and dual combinations. So we came and on the preferred fixed doses, we have the combination of ARB and the thiazide-like diuretic, of which is clothalidone. We have also the calcium blocker and the diuretic, which is the amlodipine and the clothalidone. And also we came also and have ARB and the calcium channel blockers, which we have as temistatan, amlodipine. In the market, our brand of ARB and our diuretic is Meriran. While the one of calcium calcium blocker and diuretics, we have aniline, and the one of ARB plus our calcium calcium blocker is Cotrimine.
Conclude, please.
Okay. So in this, the Cypress we have, our brand of clothalidone is known as Cypress. While our other drug combination is Mediran, and in the market, while we have the Mediran of 40 milligram of temistatan and clothalidone of 12.5, we also have a higher strength of temistatan 80 milligram plus the clothalidone 12.5 milligram. And that one is called Mediran Forte. We also have the aniline, which is the calcium calcium blocker, and the diuretic, like diuretic, which is we call aniline in the market. Then we have the Cotrimine, our ARB, our calcium calcium blocker plus our ARB, which is amlodipine and the temistatan. We call it Cotrimine.
Thank you.
In the market too, it has 80 milligram and 10 milligram, and that one is the brand is referred as Cotrimine Forte. Then we have the Tensivine. Our Tensivine is of the triple combination, which I told you. To achieve that, you have about 25% of your hypertensive patients need this product.
Thank
and
you,
we
Nimel.
have a higher
Nimel,
brand
thank
of
you.
it, of that, which is
Don't worry, they will come to your stand.
Thank you very much.
They will come to your stand to see the various strengths and combinations. Thank you very much. Let me quickly call on the representative of JAV Pharmaceuticals. Your time starts now. I've started counting even before you get here. Sam, please get ready.
Thank you. Good afternoon, distinguished pharmacists. It's a pleasure to be here. So I'm pharmacist Nduka from JAV Pharmaceuticals. So we want to quickly introduce again topic cream because it seems there may be one or a few of us that are not so familiar. So let's reintroduce it today. Okay, so topic cream, as we can see on the screen, is synonymous with feel-good dermatology. So feel-good dermatology is just referring to that the products are for dermatology, for skincare, and we know that the skin is actually about the most important organ, or the biggest organ in the body rather, so it needs a lot of care. Okay, so to achieve the feel-good dermatology, topic cream has like 7 pillars that they use to base their expertise upon. And in dermatology, the first pillar is about that protective moisturization. This is very, very important. And because of that, topic cream, every product has about 24-hour moisturization. That is very important. Then there are other pillars which includes that, because when you are using a skincare product, a lot of people worry about the ingredients and then what it portends for them. So topic cream uses only high tolerance ingredients with proven efficacy. So we don't have so much time to dwell on that, but the thing is that any topic cream product you pick up, you don't have to worry about the ingredients because it's only ingredients of high tolerance and also proven efficacy that is used. And another pillar there is that these products are formulated and clinically tested on sensitive skins, because a major fear people have in using skincare products is that the skin may be sensitive. No, this has been tested on sensitive skins. And from my slide, you can see that more than 3,000 sensitive skins were used in the various clinical trials. And then that leads me to my fourth pillar, which is scientifically proven efficacy approved by patients. So here we say that more than 12,000 healthcare professionals, including pharmacists, dermatologists, and toxicologists, and pediatricians, and so on, have been involved in the clinical trials of these products. So they are products that you can rely upon at any time. Then our fifth pillar, which is synonymous with topic cream, is feel-good dermatology. And this tries to tell you that any topic cream product you pick up is something that will give you a pleasant feeling, and nobody ever regrets using a topic cream product. So we can assure you that with topic cream, you and your patients will always be satisfied. So we have many other pillars, but these are very important. And based on these scientific expertise, topic cream has produced a range of products that are in different categories. And then there are products like the ones I displayed here that are for the body, and there are some other special products for the face, like the ones on the screen. Okay, so I will just, because of time, I will just be very brief and mention a few of the important ranges we have in topic cream. One of the ranges is our Mela range. So the Mela range is actually the experts care products for hyperpigmented skins. So any skin that has dark spots, pigmentation, and there are concerns regarding that, topic cream has got a range of products, including a hygiene product, which is the Mela exfoliating bar, and then it has a body milk, which is the Mela unifying body milk. So this takes care of hyperpigmentation on the body, and there is a range of products for the Mela face range. So when you have hyperpigmentation, dark spots on the face, topic cream has got a range, including the serum, the day cream, the night peeling cream, and a mask that takes care of that. Well, these are summaries, but I know a number of us may ask, what are the active ingredients in these? Are they things that we should be afraid of? No, you shouldn't be afraid of them. We have very excellent active ingredients here. For the Mela range, there is a patented Mela complex. So this is unique to topic cream, and then it's the Mela complex comprises of algae extract and niacinamide. So these are natural and very good products that have been well tested. Another active ingredient that you find in topic cream is this octadisenodoic acid, which is an extract from sunflower oil. And the extraction method of this actually won a Nobel Prize. We will talk about it later because it's an extraction process that doesn't use solvents. So here I try to show some of the test results. As I said, there have been a lot of clinical trials, and then there are a lot of very good results. But the summary is that within 28 days to 56 days, you can see excellent results in resolving hyperpigmentation. So we can trust Mela on that. So the results are so many. And what I will say is that because we don't have the time now, I will always invite us, let's try and meet the topic cream range at the stand. Let's have your contacts and we'll give you details. And also we promise to visit your various institutions and visit you particularly, and we keep talking of this. But then the summary is that these products are available from Joe Pharmaceuticals, and we always available to make it make it accessible to you and your patients. So on this note, I say thank you once more, and then I believe this conversation will continue after here. Thank you very much.
Let's put our hands together for Joe Pharmaceuticals. The last presentation will be made by the representative of Sam Pharmaceuticals. Where are you, please? Your 1 minute already gone out of 10. So you have like 9 minutes more.
Thank you very much, sir. This shows that anytime we call Sam Pharmaceuticals, wherever we are, we always run to you. And that's why you actually deem it fit to give us pillar of support. Thank you very much, sir. And good afternoon, sir, distinguished pharmacist. I want to start on the existing protocol. My name is Olushoyi Adilaja. I'm here once again. Like I said, I'm a pharmacist, certified supply chain analyst, data analyst, chartered institute of marketer, and recently I passed my MSc in public health as well. So this gives a memorable occasion. All right, without wasting too much time, I'm here to tell you about menace of anemic condition. Well, there is nothing new we want to tell you about anemic that you don't know. But we'd just like to, briefly remind us of some salient things that we don't really know about hematinics. Now, what is the role or the guide of pharmacists in optimizing blood health in our patient? Okay. All right, so this is just company overview. We'll skip that. We have done that before. And now, let us take a brief look. We are looking at the global burden of anemia. Now, 1 in every 4 people is affected, and globally, we have 1.9 billion people suffering from anemia, and it's most prevalent in low and middle-income countries. Now, women of reproductive age, pregnant women, and children under 5 have been picked to be the most affected people with anemia. And according to WHO, we have 40% of pregnant women, so that means we have 28% of people that are not anemic. And as pharmacists, hospital pharmacists, we all have a role to play in combating this. Now, let us look at the main anemic cases reported in the whole of Africa. This is not something you and I, as pharmacists that actually signed an oath to prevent the life of people. This is not what we signed for. Now, what is the prevalence of this anemic condition in Nigeria? Children under 5 years, we have about 68.1%. That's under the age of 6 to 59 months. Then women of reproductive age, they have about 57.8%, with pregnant women giving us 61.1%, an overall impact. When you are anemic, or when someone is anemic, it's actually, especially in child, it leads to child morbidity, mortality, and then even in adults, it reduces work productivity among adults. Now, the prevalence and burden of anemia, I'm taking a case study of Lagos State. I'm sorry, apologies to the other pharmacists that are from other states. Now, pregnant women, approximately, they have 50% of pregnant women in Lagos that are anemic. That is half. Then the general adult population, there are 28.9% who are anemic, with women with 39.2%. And children under 5, like I said earlier, they're contributing 71%. Then what are the health impacts of anemia? Maternal and child health, we talked about it. Cognitive and physical development, especially in children. Very, very important. And if they are anemic, you may be thinking they are having one thing or the other, or they're having one disease or the other. No. Sometimes it's low level of blood. Now, let us take a practical analogy. You have a car, there is no fuel in it. Or we take a human body as a car. The red blood cells are like the engine that move the oxygen around, while hemoglobin is the fuel that powers the engine that carry the oxygen. Now, when you are low on iron, folic acid, and B12, your engine cannot get enough fuel. And what is the result? The result is what we are saying. You have to pull the car. You have to drag the car. And that's what happens when we relate it to someone who is anemic. Now, the question is, how do we choose a good hematinics? That is where I am going to. How do we choose a good hematinics? I'll tell you from statistics, we have over 200 different brands of hematinics in the Nigerian market. But you as a pharmacist, at the hospital pharmacist, at the HOD, or director of the pharmacy of the hospital, how do you choose a good one? Let us quickly look at the factors to consider why choosing a good hematinics. Number one, the composition and completeness is very, very key. The composition, is it hemopoietic? Is it hemopoietic in nature or not? Number two, the type of iron salt that is being used. Is it ferrous fumarate? Is it sulfate? Is it polysaccharide iron? And we all know polysaccharide iron are quite more expensive. Now, the elemental iron content, when orally administered, is it given a commensurate quantity? Now, bioavailability, when you give a blood capsule, a tonic to a patient, does he have enough bioavailability to take care of the low PCV? Then another thing we should consider, the gastrointestinal tolerability. Can patients tolerate what the kind of hematinics they are giving them? Another thing is dosage convenience. Is it the one they will take 2 in the morning, 2 at night, 2 afternoon, 2 at night, or the one they can just take 1 in the morning, 1 at night? We have to look at this as well. Then indication-specific suitability. Is it safe in pregnancy, in lactation? Is it safe in children? Have you considered this? Number 8 is cost and accessibility. That's very, very important. Because in the economic situation of nowadays, now people are not only bothered about medicine or about their well-being, they are bothered about the food they want to eat. Do you agree with me, sir? Do you agree with me, sir? People are bothered about the food they want to eat. Now, they are not bothered about the medicine. So if you give them something quite expensive, they will say, okay, don't worry, I will come back, but you never see them. That is one of the factors we need to consider. Then lastly, the brand trust and the manufacturer credibility. Now you have given us that credibility. You have given us that credibility by giving us a word or pillar of support. Now, does that mean that whatever is coming out from some pharmaceuticals, you are not going to adopt, you are not going to take it, or you are not going to accept it? Now, we've talked about the factors to consider. What is the solution to the right choice of hematinics? We have talked about the global endemic of anemic, the condition. I took Lagos State as a case study. Now, what is the way out? How do we choose? What is the right one? Which one do we choose? Now, ladies and gentlemen, I want to present to you Maxiron capsule. Hey, give us a round of applause now. As people have your support, we are always here, year in, year out. No, this is not a new product, but we need to, enlighten us more about what Maxiron is all about. I remember when I was in primary school, I've known Maxiron, and I'm here presenting Maxiron to you. Isn't that wonderful? We have actually stood the test of time in terms of quality, in terms of affordability. Give us a round of applause now. We are your pillars of support. All right, so I present to you Maxiron capsule. Why Maxiron capsule? What are you talking about? What is the Maxiron capsule that we don't have in other products? Now, Maxiron capsule contains ferrous fumarate, which is 200 milligram, which is the source of elemental iron. It also contains folic acid, which is 1 milligram for DNA synthesis and pregnancy support. And lastly, vitamin B12, which contains 10 microgram. Now, why Maxiron? You remember when I presented AHAPEN, I said it's a triple therapy action. Now, we also have another triple therapy, hematinics. Now, what does it do? It contains ferrous fumarate, it contains folic acid, contains vitamin B12. All these elements or components, they have individual works or indications they are doing. Now, apart from triple action hematinics, it also has synergistic formulation, which gives a sustained correction of anemia. It is quite affordable and accessible. It has improved and increased bioavailability when orally administered. And lastly, the gastrointestinal tolerability is second to none. Now, ferrous fumarate, let us do a comparison. Ferrous fumarate versus other salts. We have been talking about ferrous fumarate. Why is gluconate not better? Why is succinate not better? Now, ferrous fumarate has higher elemental iron compared to other salts. That is 32.5% of elemental iron. Then it has a better absorption, giving you more bioavailability. It has reduced gastrointestinal side effects and also improved efficacy with lower doses. This improved efficacy with lower doses, I'm going to showcase that to you in my next slide. We will understand what I'm talking about. Now, this is just a brief summary of what I said earlier on. We can see the iron salt, ferrous fumarate, giving us 32.5% of elemental iron, which is the highest, compared to sulfate and the gluconate salt. Now, according to WHO standard, we need to understand this. According to WHO guidelines, 60 milligrams of elemental iron can be provided by 180 milligrams of ferrous fumarate, 300 milligrams of ferrous sulfate, and 500 milligrams of ferrous gluconate. And we are talking about taking a dose of hematinics that will give you higher elemental iron. So as of this now, which of these has the lowest dose of iron to give you high 60 milligrams of elemental iron? Which one, ma? Ferrous what? I didn't hear you, ma. Loudest, ma. Thank you very much. All right, so this is just a comparison on dosage equivalents. Now, what are the causes of anemia and nutritional deficiency? This is not new. Like I said, this is not a new product. I'm just here to refresh our minds and memories. When our factory is well done, is finished, is launched, then we are going to be dishing out new SKUs that you will be very, very familiar with. And causes of anemia and nutritional deficiency, we have iron deficiency, vitamin B12, and inadequate dietary intake or absorption. I purposely highlighted that because that is the problem we are having today. A lot of people cannot even feed, cannot even take 3 square meals, not to talk of eating balanced diet. But how do you hide it up? From the meal you are eating. That is where Maxiron comes in. Now, okay, what are the clinical benefits of Maxiron? I said earlier, rapid hemoglobin improvement, better patient compliance, reduced GI effects, complete correction of megaloblastic and microcystic anemia. Please take note of this. And ideally in pregnancy, lactation, menstruation, and even in post-surgical. Then who are the ideal candidates for Maxiron? We all know the pregnant women, lactating women, chronic blood loss, vegetarians, and children with school stress, and even adults with work stress. So everybody is a family drug, it's a family product, it's a family hematinic.
Family drug, round up.
So I've not spent 9 minutes now. Okay, so dosing and administration. It is administered once, twice, daily as recommended by your physician. And duration is for up to 4 to 12 weeks, depending on how low your PCV is. Now, summary, why prescribe or recommend Maxiron? Complete hematinic formulation, proven efficacy and tolerability, safe in pregnancy, addresses multiple deficiency types of anemia, enhances patient compliance, affordable and accessible, no GI comfort. Now, I want to ask us, this is not a $1 million question. You are a pharmacist. Everybody seated there is a pharmacist. We are all a practitioner. What is our role? What is your role? What is our own role in combating shortage of blood, in combating anemic condition in your state, in Nigeria? What is our role? How do we intend to overcome the menace of anemic condition in our country today? So at this stage, I want to say a very big thank you. And as pillar of support, we always have your support. It is a partnership. It's a joint partnership that we have signed. It's a joint partnership that will continue to exist. And at this junction, I would like to say a very big thank you for giving your listening ears and for trusting in Sound Pharmaceuticals. Thank you very much.
Thank you very much for supporting us at all times. We appreciate you for that. Ladies and gentlemen, colleagues, we have come to the end of this session. In the next 3 to 5 minutes, the AGM is going to start. So if you want to stretch your leg, you can just move around, greet your friends, and get prepared for the AGM. Thank you.
You know, hey,
Hey, nice. Come on, how you doing? Nice. Let's go, dude. Check. Hey, my name again. It's like it's so wet. If you call it, I be the chosen one. I remain no matter of Niger land. My brain drain, working all day like say I know be my mate. The street keep urging me to do more. Once my come, this brand new own animosity. I be the grateful. I'm ever sure I'm beyond the beef talk. But you more just like a melody. All of my shikata love bad. I think you should know. So I beg you, about the make it happen. All of this is most incredible. From Nigeria, from Nigeria, street credibility, we get check my fans, my life, don't be lie, yeah, don't be lie, don't be lie, yeah, don't be lie, don't be lie, don't be lie, can you love it? As I come here before you, I will talk as I see you. I don't go use any sugar. Call me your mother, I know you understand. I know they use we always peacefully do it very nicely. Always try to work. These two friends are nice. You're ready to always nice your money. I know it sounds like bragging, but it's true that I'm talking. Can't deny God's blessing. Right now we are the zebra crossing. No cars are passing. It's just reality flashing. Oh, Jojo la loma. Inya loma. Sorry, confirm. The most incredible. I from Nigeria, still from Nigeria. Street credibility, check my fast, don't be lie, yeah, don't be lie, yeah, don't be lie, don't be lie, categorically I'm the best mentally, no gay saying I'm the cutest physically. Don't doubt me, I go bring them Grammy. Credible, remarkable, unbeatable, palatable, reliable. Yeah, kudu, I think I come kudu, yeah. I'm made of the streets, why I no go blow? Originality work for me, why I no go show? I shine why they walk go so to that oh. Now me the one to the street I belong. Enemies a must if you want blow. I'm on that tongue by tongue. Back by God, make you reach your tongue. This is just free, I'm a plenty fighter. Anyhow we go be, I'm a just walk on your way to the top. The most incredible. I from Nigeria, still from Nigeria. Street credibility, we get check my fans, I like, don't be lie.
by my poor single mother. Sweet like a govel, to my sweet sugar butter. I was born with a silver spoon, and then I lost the spoon. But I give God all the glory, yeah. When I walk out, everybody say they know me, oh. And I give God all the glory, yeah. As I sing, I tell them my story, yeah. I'm better than the best. Bitch, I never rest. Daddy, me pere mozo.